All right, good morning. Hi, everyone. My name is Joseph Corey. I'm one of the neonatologists at VCU. I'm also the co-chair for the VNPC. I would like to welcome everybody here today. This is our 6th annual summit, and over the past couple of years, we couldn't do them in person because of COVID and restrictions that we had. So we're very happy to be here in person back again. It's always good to have personal interactions with people. It was kind of hard to do that over Zoom, so we're very excited to be here. A lot's happened in the past 2 years since we last met in person. Shannon will expand on this later on when she's up here, but the VNPC moved from VDH to VCU. We added new team members to our team. Sabrina, where's Sabrina? Oh, there she is. She's the wizard behind all our social media posts and everything. We can't do that. Shannon is the executive director of the VNPC now. So we've done a lot of things since then. We are in a much different place than we were when we first started 5 years ago. I'd just like to thank everybody who's helped us come along and with this journey. So we're looking forward to hearing from everybody speak to us today. I hope you are too. And one major change I didn't mention was that Donald, I don't think he's a stranger to anybody in this room. He retired from the VNPC in July, stepped down as co-chair. So I'd just like to invite him up here for a minute or two just to talk to us. Come on, just say hi. Well, just say hi.
Hi.
He's usually very timid, so he doesn't say much.
Shannon said I didn't have to say anything, but now he tells me I have to say something. So thank you all for coming. I'm excited that we're all here in 3 dimensions. It's really quite a treat. Yes, I did step down from the obstetrics co-chair. Every organization needs new fresh breath every now and then. I'm now in kind of a phased retirement at University of Virginia, so I'm only working part-time, so I don't spend as much time in Virginia as I used to. So I thought it would be best to have step down, and we were fortunate to find Arthur Ollendorff. Arthur, stand up, wave your arm, kind of do something like that. To become the obstetrics co-chair, and he has a wealth in perinatal collaboratives, having served similar roles in North Carolina before he came here. So I feel confident that the group is in great hands. When you raise a kid, you kind of raise them from a baby, and they walk, and then they start to run, and Shannon's going to tell you we're running, so it's kind of like, I kick you out of the house. I'll be kind of like a bad case of athlete's foot. That is, I'll come back and irritate you every now and then. But I'm pleased to see everybody here and to see the growth of the group. And it's with Shannon and Joe and Jen from the state and Barb Snap and Joan Williamson and VHHA. We couldn't be here with all this. It is a collaborative after all. It's not about me. So anyway, have a great day.
Thank you, Donald. So as Donald mentioned, Arthur joined us in July, and we're very excited to have you. We did learn a couple of things from Donald about collaboratives and summits. They have to have bacon and tea. So hopefully Arthur will tell us soon about what he'd like in summits too. So anyway, just speaking of that, so next July, I'll be stepping down as co-chair from the VNPC because we want to stagger it. So we'll be sending out an email soon to start looking for new blood from that standpoint as well. And last but not least, I'd like to welcome Deputy Secretary of Health, Mr. James Williams, to come up here to the stage and talk to us this morning. Thank you for coming, and we're looking forward to hear you speak.
Well, thank you for inviting the governor's office to open up your summit, and glad to hear you're back here in person. I have to say, my wife just gave birth to our first daughter, and no number of books can prepare you for everything that happens in delivery and after. So just want to say thank you for all that you do. Extremely important. We personally had a doula, and it was extremely helpful to have, just a trusted voice who kind of walked through the whole experience with us. And so, I know that very well now, but I'm also happy to report that we are supporting the doula program in our Medicaid program as well. And one of the things that has been really exciting is we've now registered 50 doulas in that Medicaid doula program so far, which is really exciting. And we've actually had the first birth on October 1st of this year that was doula supported in the Medicaid program. So really exciting work there that's going on. I think there's you all know this very well, but our maternal mortality review team kind of assesses that roughly half of pregnancy-related fatalities are associated with medical error or lapses in care. And so we see that as a really significant opportunity to address that where there are lapses in care. So that doula benefit in the Medicaid program will include 4 prenatal visits, the delivery, and then 4 postpartum visits as well. So really kind of expanding access to care in the 4th trimester. One thing I also want to touch on is, I think you all will be kind of looking at this later today, but I'm glad to see that you're talking about heartbeats and, some of the newer models of care later today. But, there are some really sad statistics that our maternal mortality review team also looks at, including domestic violence and suicide. And so I would just encourage you, I don't think that we have all of the answers in the governor's office, so I would encourage you to actually, send us some of your thoughts from your discussions today, emerging research. It'd be great to hear from this group on what should we be doing and what should we be thinking about. For example, how can we have a better connection to our 988 mental health hotline, which is new in Virginia. We've kind of rolled that out and been successful with that this year. But how could we incorporate maternal health into a mental health crisis hotline like that, and into other kind of pathways of care? So just a bit of a challenge for you all here today to think about that. In general, I think we also think that some of the problems here are regional. And so not everyone throughout the Commonwealth has access to the same level of care. So just because you have insurance doesn't mean you can get access to the care you need. So we have a concerted effort to expand access to providers in Petersburg and the Hopewell area specifically, just because there are not enough providers there. And so we're looking at, can we expand access through our federal partner provider programs, and then also working with private providers like Bon Secours to actually stand up, expanded hours there. So again, on issues like that, would love to hear, if there are mobile clinics or things like that you all are aware of that are really effective. Would love to hear, about what works and what doesn't work in your area of care. So thanks again for inviting us to open your summit, and look forward to learning from you all. Thank you.
All right, thank you, Deputy Williams, for sharing all that information, and thank you for joining us for today. So a couple of housekeeping or maybe exciting things. If you guys joined us for the reception last night, there was lots of giveaways. So I do want to draw everybody's attention to this back room. We do have a digital recorder for our presentations today. So it will be captured. Things will be captured. It'll be available on our social media sites. But I want to draw attention to the back poster, which was what captured our discussion from last night at the reception. While it was networking, we also did some work. So that is what we did last night. So I definitely want to do that. I also want to draw attention. We have a couple of posters that are hung up in the room. So please take a look at that as we're moving around in between breaks and lunch. Everybody in their folder should have a VNPC bingo card. Please participate. And what we're going to do is we're going to take the honor system. If you complete it, then you will drop it with your name at the front desk once you're done. So just check things off as you go throughout today. And there will be prizes if you join us back here for the closing remarks. So I just want to highlight that. So definitely participate in that. You all have been around a little bit. You guys know I've printed this, and there's already been like, I don't know, a gazillion changes. So I apologize in advance for the agenda. It's not the most up to date. But I do want to bring everybody's attention to what we're going to be doing for today. So the Eliminating Bias in the Dyad Care is our first breakout session. It will be in this room. And then the Project Empower and Heartbeats you only have 2 to choose for the first breakout. Will be in this room right behind me. And then we're going to have 10 minutes in between to basically move rooms, grab food, run to the bathroom. And then back in this room, we will do the Women's Veteran Program. They'll be presenting in this room. And then you can either go to the Eliminating Bias or the Project Empower. So if you didn't join the Eliminating Bias for the first one, you can jump to that one. So again, I will leave the Project Empower will be in this room right here. And then directly behind it will be the next breakout. So we're kind of in a square here. So diagonal will be the Eliminating Bias. So first session in here, second one will be behind us. And then for this afternoon, we will have another set of breakouts. The workshop part 1 and part 2, if you go to the first one, we're asking that you join us for the second one. So this one you're not going to change. We're asking that if you commit to that, to please stay for both of them. That will be in this main room. 4th trimester program will be in this breakout, and we'll direct everybody. So you don't have to commit this to memory. And then the ultrasounds are in this one, and then the 4th trimester will be diagonal from here. So I will be around if you have any questions. We'll make sure we steer you in the right direction. I also want to draw everybody's attention to the tables. You should see a green card. Please use the hashtag as you capture photos throughout today. There's also a selfie wall. If you go back to where the registration is, please participate in that. It's lots of fun. There's props and everything. But as you're taking pictures, please post them on social and use hashtag VNPC 6th annual. And then I also I promise only like 2 more announcements and then I'll get into my actual presentation. The purple one, so we are not passing the mic today. We're going to actually do virtual Q&A. So as the presenters are talking, use the purple sheet, scan it, and then you can actually text in your questions, and then we will moderate at the end of the sessions. If we do not get to all the questions, the presenters are aware of this, and they will actually respond to your question virtually. And then we'll do a printout of that. So everybody's questions should get answered. And then one last thing, this yellow one, use the QR code on here. The bios are uploaded to that, the agenda. Everything you possibly need is on the link tree. We're going to have a presentation later today for CDC Locate. And the actual, Mary's excited. She's with VHHA. We partnered with them to do this. The actual survey, not to one to complete, but to look and see, is on that link tree as well. So just check out the link tree. There's a lot of links, no pun intended, with all the information you could possibly need for today. And then one more shout out is we have t-shirts. My volunteers from U of R, will you stand up, please? So we have done something different this year. We actually created t-shirts, and the whole idea behind this is we're trying to engage and have more social media and really try to be the VNPC outside of this room, because when we all go back into our everyday jobs and we're spread throughout Virginia, we still want to have that presence with the VNPC. And so we are going to pick random days, if you follow us on social media, to wear these shirts, and then we will be giving away incentives for that day of people that actually take pictures and post. So it's a fun way to kind of all be together even when we're spread throughout the state. So the t-shirts are available at the registration desk for $15. All of that money goes right back into the VNPC to do projects, so it's going for a good thing. And they're super soft. I've already had some feedback. They're really soft, so you guys will actually want to wear them. We have small through extra large there. If you need a different size, we will be placing a pre-order. And if people are not here today, they can still order it. The link will still be open. So I want to put that shameless plug out there. All right, now we'll get into what the VNPC did for the last couple of years. All right, so Joe kind of touched on this a little bit. We did move in May of 2020 from the Department of Health over to VCU University. We launched the Maternal Quality Care Alliance, and I want to highlight that's what we're going to talk about for our part 2. They're working on their strategic plan, so you guys will be a part of that if you want, if you join us for the part 1 and part 2 this afternoon. As I alluded to a little earlier, we've really worked hard to establish ourselves on social media with a presence. I finally, for all of you that have been around a little bit, hired our first FTE besides myself, so I doubled our staff. And then we've also created a maternal health disparities dashboard. I will highlight that here in a second in partnership with VHHA. And for those of you that don't know, we have paid over 40, paid for over 40 hospitals to actually have access to that. I'm not currently utilizing all of those licenses. So if you are a hospital that you don't know if you're utilizing that or not, please see me throughout today because I would like to get you guys plugged in. It's a paid access for 1 year. And I'll highlight some of what the dashboard can do here in a second. But if you participate, and we're hoping everybody will, throughout the next couple of years, participate in a quality improvement project, you will also get access to that dashboard for as long as you're participating in that quality improvement project, paid for by the VNPC. Another thing that we did, as Donald said, we're actually running now, is the fact that we now have a data platform which is specialized in quality improvement, and that is LifeQI. So for those hospitals that are currently doing our project formerly known as the 4th trimester, we'll talk about that in a second, they're actually able to submit that data to LifeQI and get immediate feedback on run charts over over their time. So it gives you that immediate feedback, whereas before you guys were submitting data to me, I was uploading it, and then you were still having to create charts on the back end. So that's been a huge success. The other thing I did not put on here, and I probably should have, is that we have actually been we've been funded for 2 grants. So we now finally have a little bit more sustained funding. So our first one is with the CDC Perinatal Quality Collaborative Grant. It is an annual grant for 5 years, and what that is to increase participation in our quality improvement projects throughout Virginia, and then to expand the number of projects that hospitals are participating in. And then we also, our second one in partnership with Maternal Mortality, I'm pointing over here to Melanie, who's our project manager for the Maternal Mortality Review Team. That is a 2-year grant where we are a sub-awardee to actually look at past maternal mortality grants and to see what of the recommendations were implemented and what were the benefits or the barriers and challenges on whether things were implemented, and if they weren't implemented based on those recommendations, what were the barriers or the challenges for getting them implemented. So I'm happy to say that we now have 2 additional grants that we are working under right now. So this is the maternal health dashboard. This is just a snippet, and it's very small. I apologize for those in the back. But this just shows you the wealth of what we can actually do with the maternal health dashboard. So if you look at all the identifiers up at the top, and again, it's very small, but to see, we can actually pull down all of those drop downs, and we can differentiate between what is going on with these. So we can look at hospitals, we can look at zip codes, we can look at payer, we can look at race or ethnicity, we can look at chronic conditions. There's a COVID identifier in there, so if mom was positive for COVID at the time of delivery, we can filter out outcomes based on that. So there's a lot we can do with this dashboard. And like I said, we have paid for these memberships. So they're not memberships. We've paid for these licenses. So they're available. We would love for hospitals to actually be utilizing this and using this as a foundation of what their needs or strengths are to then inform the projects that they do. That's the parallel. And at the end of the day, this is a start, but you should be asking questions based on what the data shows. I'll give one example. I won't say the hospital system, but I pulled data specifically for one hospital system that has multiple hospitals throughout the Commonwealth. And in pulling this data, I noticed that with this specific locality, that one of the chronic conditions that came up for this locality, different than all the rest of the states, was that they were actually comorbidities and chronic conditions with STIs. So that tells me that that's an opportunity for us as providers to provide additional information as it relates to STIs on discharge with the baby. And that's something we did not see in the rest of the state. And so that's what utilizing this dashboard can tell us, like opportunities on how we can better provide care for our families and our pregnant and parenting moms or baby families and their infants. So, and then, I'm sorry, one more thing is, of course, we can see the age distribution again, and then another thing that's major at the top slide up here with deliveries by DGR or DRG, we can actually look at section rates. We can look at sections rates by age, by race, any number of things. So this really has that capacity to where we can really drill down a wealth of information. All right, so moving on. Another thing, as Donald had mentioned, we're in the running phase. So we're the 6th annual, so we've been around for 6 years. But to date, we had not done a strategic plan. And so many of you that have been around with us, we were very reactive to different projects. And we didn't really have a clear, honed-in track on what we needed to do. So we just, we're wrapping up our strategic plan. And we've narrowed it down after doing over 100 interviews with community members, healthcare providers, a very wide range, and then having a couple of different focus groups. We've drilled down our priority areas down to 4, so health equity, communities, data, and communication. So moving forward, those will be, for the next 3 years, the 4 priorities for the VNPC. The strategic plan will actually be published here relatively soon. We're just finishing up a few little minor details, and then look for that to be published, and that will be available for everybody. As I mentioned, everybody might be aware of the 4th trimester project. That is no longer our name. We've been asked to change it because it was trademarked, and so right now our kind of running joke is the project formerly known as the 4th trimester project, because we don't have a name for it yet. So stay tuned. Later today, we've got a couple of options that we're kind of mulling over, or I'm open to any suggestions on what we should call this formerly known as project. But if you look back at the wall over here on the right-hand side, you can actually see what the project is and what we're doing with it. So that might spark some interest as far as what we should name this said project. I have to rename it by October 31st, so time is kind of an essence. So if anybody has any wonderful ideas, otherwise it's going to be PRITS, the formerly known as. And then our next project, we're actually getting ready. I don't want to give anything away. I don't want to take anything away from Dr. Holland and Dr. Ollendorff, but we are going to officially launch the Eliminating Bias in the Dyad Care project today, so hospitals can start onboarding next month for this project. Antibiotic stewardship, we are sending around a survey for NICUs and newborn nurseries to participate, because we need to see kind of where the lay of the land is as it relates to antibiotic stewardship. And then that will kind of drive what that project is going to look like moving forward. And then, you guys, I'm going to do very brief, but Carla from CDC will actually be presenting this afternoon. But we will be launching Project Locate. Again, I'm not going to jump ahead in the schedule, but definitely there'll be more information about that this afternoon. So really quickly, this is kind of what the phases look like for our fourth trimester. I mean, the project formerly known as. And so a lot of our hospitals are implementing either in phase 3 or phase 4. And then we have one hospital system that is actually implementing under the topic. So for those of you that are a little bit more familiar with this, and the poster back there highlights it, we have selected 5 topics under this project: maternal health, perinatal mental health, human milk feeding, reproductive health, and preventative care and counseling. So we have one hospital, and you all will hear about it if you join the fourth trimester presentations. They are actually implementing perinatal mental health across all 6 phases. So that's how you can either implement across subjects or by phase. This is a very robust project. It's not one and done. If you guys commit to this, you're joining us at the VNPC for the next 3 to 5 years, because that's going to be the time that it's going to take to implement across all 6 phases and all 5 priority areas. And this was working closely with the maternal mortality review team as far as what are the needs of our families and communities across Virginia. And then I already put the shameless plug out there for the VNPC t-shirt, so I'll put another plug real quick. Get your t-shirt today. And that is it. So thank you. And I am going to actually turn this over now to Nikki Montgomery. She is going to be our plenary speaker today. So while she is coming up to the stage, I want to give a warm welcome to her. Let me know what you need. And my apologies real quick for social media. I just said that. Everybody's like, you should take a picture while you're up here. So really quick, everybody, so we can post this. I need everybody to smile. I'm going to go this way first, and then we'll go. All right, I'm not that high-tech, Donald. All right, thank you, guys.
So good morning and thank you, everyone. I'm Nikki Montgomery. I'm a patient and family advocate, and a lot of my work has been in hospitals and healthcare settings related to my experiences of raising a child with medical complexities and having some complexities in my own pregnancy with him. I'm going to go through a few slides today to kind of direct our discussion here, but I really want us to focus on who we're engaging and how we engage them. And so that's why we're talking about how words matter today. I'm going to introduce you to another person, Mary Catherine Beach, via video today. And she's a researcher who does a lot of work dealing with how bias shows up in doctors' notes. So I'm going to play a video from her. And then after that, I'll get into a little bit more discussion about how this shows up from the patient end. And I should be able to click right on this, right?
Thanks so much, Nikki, for those important reminders. And it's so wonderful to hear the connection between this topic and your former life as an English teacher. Nothing that's shared on this webinar, as Nikki said, is revolutionary, and unfortunately, harm to Black and Brown patients is far too common. And so with Nikki's words in mind, we will now hear from Mary Catherine Beach, who is a professor of medicine with a joint appointment in the Center for Health Equity and the Berman Institute of Bioethics at Johns Hopkins University. Dr. Beach's research focuses on humanizing healthcare by promoting respect for patients, as well as improved patient and clinician communication. Much of her work has been aimed towards improving healthcare quality for patients who face systemic disadvantage. Dr. Beach has won numerous awards for her scholarship and mentorship, and we are incredibly lucky to hear her speak on her research today. I have no doubt that you all will find her work eye-opening. Dr. Beach.
Thank you so much. Okay, so I am going to talk about several different stages of work where we began to document how the language that's used in medical notes can adversely impact patients. So first, I'm going to talk about different types of stigmatizing language, so we have a really clear sense of what language we're talking about. Then I want to show you how we can look at the impact of that language on patient care and healthcare quality, look at whether the studies on racial bias in the use of that language, and then finally end with a few preliminary recommendations. So we've done several studies where we've looked at the ways in which doctors write about patients, and it is most common that negative attitudes towards patients come up in a very implicit way, rather than writing something explicitly negative. Physicians have become skilled at writing negative things in more subtle manner. So rather than describing someone as unpleasant, they might put details in the medical record that demonstrate why they think the person's unpleasant, and yet these details are medically completely unnecessary. So writing, quoting a patient in a way that might make that patient look like they're uneducated, using African American vernacular, in such a way that there's no added value at all to doing that in the record. There's also ways in which doctors indicate that they disapprove of the patient's behaviors. For example, she reports that if she were to fall, she would just, quote, lay there until someone found her, indicating that obviously the clinician did not think that was a good plan and was frustrated with the patient for not taking up the physician on the advice that they were making to have a medical alert. There's another whole theme around how clinicians undermine the credibility of the patient. And this is going to come up later in the talk, but saying things like he insists the pain is behind his knee, claims the nicotine patches don't work for him. Those are phrases that directly contradict what the patient is saying, and it begins to document just how much distrust clinicians have of the patient's stories. And in a further study around this theme of undermining credibility, this work that I'm describing really began in the realm of sickle cell disease, which is a condition that I have spent quite a bit of time working in. And there's direct statements in medical records of people with sickle cell disease to suggest that they're lying about the amount of pain that they have. And this, I think, is the primary cause for why people with sickle cell disease get their pain undertreated. So for example, it's not uncommon to have the clinician write that the patient has narcotic-seeking behavior when they're presenting with a vaso-occlusive crisis. But even more common is these indirect or implicit ways that clinicians express their doubt. So they will juxtapose the patient's report, which is supposed to be objective, with some discrediting clinician report, like the patient reports 10 out of 10 pain, but the labs are stable. Or they'll indicate that the patient's chatting or conversing lightheartedly to demonstrate that they don't actually think the person is having as much pain as the person is saying that they're having. Another way that they express doubt of people's pain is to use quotes to say that the pain medication is, quote, not enough, or the patient states, I am in as much pain as before. And then finally, as you saw earlier with the verbs claims, insists, reportedly, there are these signals that are directly discrediting to the patient. There's another theme that came up in sickle cell disease, which is a way that clinicians can place blame on patients. So in particular, that is often done when they highlight non-adherence in a way that suggests judgment. So not wearing mandatory oxygen, uncooperative, or using words like refuses. Those are ways in which we say this person is actually responsible for their whatever bad thing is happening to them because they haven't been following advice. There are actually positive things that clinicians say as well about their patients. clinicians do make direct compliments. You will say people are charming, pleasant, kind, delightful. They will make remarks that convey approval of the patient's or enjoyment of the patient. They will sometimes, when they document non-adherence, there's this whole category which we'll call minimizing blame. So they'll document the non-adherence, but they'll explain why. So that really humanizes and minimizes the blame that someone reading that might have about the patient. So she's not been checking her morning glucose because she lost her glucose monitor, or not taking iron because it makes her constipated. And then finally, there are personal details that the clinician might put in their note that would humanize the patient for the next clinician who's reading the note. So when you see something about someone that they enjoy walking with their fiance and their dog named Scout, that helps you relate to the person you're reading about as a person. Now, just going back to that stigmatizing language, one of the first studies we did was to try to document whether, if you put this language in the medical record, we always thought it was like a reflection of bias, but the question was for us then, does it propagate bias? Like if somebody else reads that language, are they going to have bias against that patient because the language is there? Which might seem like an obvious question. I mean, I think it kind of is, and yet somehow we need studies to demonstrate this so that we can, convince people that this is important. So this was a study we did where we created vignettes of where we used stigmatizing language, and then we rewrote the vignette with neutral language. So these are hypothetical patients, and we were able to then randomize clinicians to read one of the two vignettes and see whether, if they read the vignette with the stigmatizing language, did they have more negative attitudes towards the patient, or were they less likely, were they going to give lower doses of pain medication as a result of that language? And so we used examples of stigmatizing language that we had found in actual medical records. So, for example, a nursing note said, he is insisting that his pain is, quote, still a 10. His girlfriend is lying on the bed with her shoes on and requests a bus token to go home. And so we wrote it and said, he still has pain rated 10 out of 10. His girlfriend is by his side, but will need to go home soon, because the other details are frankly irrelevant. And what we found was not surprising. There's an attitude scale that we had developed so that higher numbers mean more positive attitudes, and the numbers themselves don't exactly really mean anything. It's just to show you the magnitude of the difference. But in the neutral language case, the mean attitude score, positive attitude score, was a 25, whereas in the stigmatizing language case, the mean attitude score was a 20. So, 5 points, it's a hypothetical scale. The point is that there was an impact and it was statistically significant, so that stigmatizing language led to more negative attitudes. Similarly, with pain management, the higher the score on this scale means that the clinicians prescribed higher doses of pain medication. And so in this case, if you were in the neutral language condition, you prescribed your pain management was at a level of 5.3, whereas the stigmatizing, it was significantly less at 4.7. So you can see then that if you put the stigmatizing language in the record, the people reading it are going to be less aggressive in the pain management that they deliver to the patient. Now, we also then took the next step, as have several other people. I'm going to show you a couple of studies here to try to see, is there a systematic pattern demonstrating racial bias in the use of stigmatizing language? And the first study I'm going to show you is not one of ours. This was a study published quite recently in the journal Health Affairs, and it was called Negative Patient Descriptors. And in the top right of the slide, you can see the various terms that these authors searched for in the medical records at a large academic medical center. There were terms like adherent or non-adherent, aggressive, agitative, angry, challenging, etc. And they looked to see whether there were differences by race and by gender. And they found significant differences in those languages, so that there were, if you were a Black patient, you had a 2.5-fold odds, so 2.5 times more odds of having one of those descriptors in your medical record compared to a white patient. And if you're Hispanic or Latino, you had about 1.5 times the odds, so about 50% more likely to have one of those descriptors in your record. Following up on this issue of whether Black patients are more likely to be disbelieved, there's a quote in the Chicago Tribune from an article that was called 9 times out of 10, I was completely brushed off. And he says, if there was ever a book on medical racism, it should probably just be called They Don't Believe Us. And along those lines, in previous work that I've done, when I have interviewed people about the term, like what it means to be treated with respect, it was striking that in our African-American focus groups, people described being treated with respect as being believed and taken seriously. So, you know, what that 9 times out of 10, I was completely brushed off. These quotes are also from people who have had that same experience. So, you know your body, when you come in a position of being controlled, you know yourself, or you cannot tell me there was nothing wrong. And that came up over and over again. And if you think about what we're seeing in medical records, where clinicians are expressing that they don't believe what patients are saying, and you match that up against what African-American patients have been saying for a long time, you can see that there may be a way to document objectively that people's experiences are discoverable by looking in the medical record. And so we did a study where we looked at various markers of doubt, you know, drawing on that work that I had shown in the beginning of the talk, whether there were judgment words like insists, claims, apparently, reportedly, adamant, those kinds of words, or whether there were quotes used in medical records. And we found that there were significant differences by race in the use of all markers of doubt. So for example, in the medical records of Black patients, there were 29% had a judgment word compared to 21% of white patients. And that was about a 25% increased odds of having one of those words used in your medical record. And the similar finding was had with looking for quotes. So I just want to summarize and make some reflections and recommendations. First, I think we've shown that languages in the medical record can convey people's biases, that it perpetuates stigma that influences subsequent providers who care for the patient, that it may reflect or perpetuate testimonial injustice, especially for African-American patients, which is something I think we need to pay a lot more attention to and hasn't gotten enough attention. And I also want to point out that now that patients have access to their notes, there was a study that found that 1 in 10 people who were able to look at their notes found something that they were offended by or they felt judged. And this study, linked here in this slide, shows all the different ways that patients can be offended. And a whole big category of that is just disrespect. So not being heard or being misquoted, having someone be condescending. And those are things that I showed you in the beginning. Like, we can see these things in medical records, and obviously so can patients. And so when I talk to a group of clinicians, I make a couple of recommendations, and I'm sure many of you have some other recommendations, but a couple of them are to avoid expressing frustration with patients. Like, don't include, if you're personally frustrated by somebody, you have to check yourself and take a deep breath and step away from it and realize that's you. Stay aware of your own emotions and don't put that language in the medical record. Strive for testimonial justice. And by that, I mean, second guess whether what you think someone's telling you, if you think somebody's telling you something untrue, or, you know, that they can't remember, they're just not, even if they're not lying, if you think that they're just not telling like the right story because they don't remember, check your assumptions on that. And when you're documenting something in a medical record, don't use words like claims and insists, where we directly contradict what somebody has told us. When somebody is non-adherent, try to express why. Try to think about what's going on in that person's life. Don't label people as non-adherent and make it a personal responsibility issue. Just try to think more broadly about the patient and think about ways in which you can minimize the personal blame for someone who's not able to or is not interested in following the advice that you think that they should follow. And then I think just really be very careful with quotes. Quotes have become a convention in medical documentation. People do it all the time. I think that there are many negative ways in which quotes can be used. And I think clinicians should very rarely use quotes. And when they use them, just be very careful. So I just want to end there. Thank you. I look forward to hearing the other speakers and then hearing your comments and your questions.
So thank you for listening. Mary Catherine was not able to be here with me today, and she and I have presented a lot on this topic. Thank you. But I did want to share what her words and study were, because I think this is really essential to us having a shared understanding of what some of the problems are as they present. So I'm going to now go into some of my own comments and my own experiences, but just know that she was sad that she couldn't be here today, but she was already on vacation, so she couldn't come. But some of my background related to words and how words matter are that in addition to being a patient and family advocate, I have a bachelor's and a master's in English. So writing has been something I've done many, many years. And I'm an author of 8 different books about healthcare and taking care of complex children. My background is also in critical thinking and dealing with health literacy for families of children with complex needs. And I have a certificate in patient advocacy. My personal experience has dealt with pregnancy loss, high-risk pregnancy, and having a child with a rare genetic condition. So we've had a NICU experience and lots of medical complexity over the years. He's 11 years old now. So we've had lots of triumphs in that time, but also lots of complexity, as you can imagine. So I want to talk to you a little bit about critical thinking here, because I do think this relates to how we use words. And when we're thinking really quickly, we have that fast processing, and that's called a type 1 process in your brain. It's fast, it's unconscious, it's a kind of shortcut to the information you need. And a lot of times we do this. It's a human nature thing, right? You see an orange and black striped large cat, and you know instinctively you should probably run because that's a tiger, right? So our brains are made to do that for our survival. However, in certain situations, this is not the best way to think. Our slower processes, our conscious processes, that's the critical thinking that's going to get us at the heart of relationship building in healthcare. So I want you to think about how your brain works as we do this. And for those who are unfamiliar with the term bias, I wanted to include a definition here. I used to be an English teacher, so definitions are very important to me. But I do want to make sure we understand that it's just a tendency in our brains to think a certain way. It's not something we necessarily have to feel blame about. It's a program thing that our brains do, but we do want to be aware of our biases. And some of you may be aware of some of the ways that you can assess biases, and we'll talk a little bit about that. But essentially, your biases can be explicit, you can know about them, or they can be implicit and you cannot know about them. And the ones that are implicit are usually the most insidious ones because we don't know they're driving our decision making. A lot of the things that I want us to think about today are really intersectional, that there are lots of different characteristics people experience bias for: age, disability, gender, race, and ethnicity, all of these other things that you see on the screen right now. And I want you to recall that many of us come into healthcare settings with multiple identities that experience bias. And so those who come in with these multiple identities are also at further risk of the harm that we experience because of bias. So when we talk about how you assess your bias, has anybody taken the implicit bias or implicit association tests? Lots of people have, right? Okay, and that's often a start to how we train people about bias and how we talk to them about bias. I think the biggest concern that I have about these tests is that they're just a moment in time. So they only assess what you think at that moment. And also they are not intersectional. They separate out identities. So how do you feel about people with disabilities? How do you feel about people of certain races? But they don't combine these factors. And many of us are a combination of these factors. So how does this affect us when we're in front of you? And I'm Black, I'm overweight, there's an assumption of class because I'm Black, I'm female, all of these different things that I bring in my body into healthcare. How does that affect how I'm perceived and how I'm treated? So a lot of times that bias still shows up. The bias in healthcare has been shown to reflect bias in society. And so that means that 60 to 80% of the general population have anti-Black biases. So 60 to 80% of medical providers have anti-Black biases. That's uncomfortable to sit with sometimes, but it's the truth. And those of us who are encountering healthcare in these bodies and in these identities are experiencing that in real time. So how does it show up? A lot of times it shows up in how communication happens, and that's the essence of this words matter. How do you communicate with your patients? Are you directive or are you collaborative? And a lot of times the studies show that Black patients experience communication that's very directive. I'm going to tell you what you should be doing with the assumption that you don't know that, versus let's talk together and find out what your challenges are and build solutions together. A lot of times it's just how friendly you are. And this can be anywhere in the healthcare setting, from the front desk to the clinician to heading on out the door. Responsiveness to concerns, we heard about that from Dr. Beach, and the responsiveness to pain. And then also what treatments you recommend. And finally, as she talked to us about, notes about the encounter actually show some of this as the physician experiences it, but not necessarily as the patient experiences it. So these experiences of bias can get a little more detailed. It could be profiling. I'm assuming that your problem is related to your diet, your weight, certain things like that. It could be that there's a kind of self-righteous attitude about knowing what the patient needs without asking. Being disrespectful in multiple ways, and we saw that in the notes, but also being dismissive of what the patient is saying, which we saw from Dr. Beach's work as well. Withholding options and having differential care, establishing a difference in power. And then some of this actually has an effect on how care is proposed to happen. Patients are often blamed, and then they're often assumed not to know what is going on with their own bodies. And finally, there's a lot of experiences of outright racism in healthcare. So the evidence that this is true, if we don't believe what patients are saying, is also in the outcomes, right? Like when we look at health outcomes, when we look at perinatal outcomes, when we look at all of these different factors that we're concerned about, we see disparities there. So the disparities are a reflection of some sort of reality that's not just centered in the body of that patient. The bias they're experiencing is showing up in real life. And some of the numbers, there was a study by Robert Wood Johnson Foundation, and 32% of African Americans who participated said they'd experienced discrimination, and 22% had avoided seeking care because of that. So often you see blaming when pregnant people don't seek care, and you're like, well, why wouldn't they seek care? Well, there are plenty of reasons they might not seek care. They've often experienced trauma in the healthcare setting that would make them want to avoid that care because they can't trust that care. So I want to talk a little bit about some of my own experiences of bias. I'm going to pull my notes here because it is very personal. It's not something that's distant from me. In my own life, I had a doctor who, when I was trying to get pregnant, recommended a treatment for my fibroids that would have ruined my fertility. He was a white male doctor, much older. I told him what my desires and needs were, and he recommended a treatment that would have ruined my fertility. Because I had done reading on this, I called him on it in the moment and said, but that treatment's not supposed to be used for someone who wants to get pregnant. And he turned red. And I could not trust him anymore. I left that doctor. I did not go back to that doctor. So then we have a change in my continuity of care. And we certainly have an undermining of my trust in healthcare from that one conversation. Another situation I've had is that when I was pregnant for the first time in 2010, I went to the hospital because I was spotting. They gave me an ultrasound. And as I stood up from the ultrasound table, I had a miscarriage right there on the floor. And as that was happening, the staff were very concerned about the amount of blood on the ultrasound floor. Very concerned about that. They were not concerned about the mental health crisis I was experiencing real time. So I'm in a healthcare setting with people all around me milling to clean up the floor, and nobody was concerned about my experience. I had a high-risk pregnancy the next year when I did get pregnant, because I was 35 years old. And my son started off as a twin pregnancy. We lost that twin very early on. But I had high-risk pregnancy, so I was going for ultrasounds very regularly. And the ultrasound tech never looked at me. I mean, I remember sitting in that room week after week, multiple times a week, and having the same ultrasound tech who never gave me eye contact all that time. So I'm bringing all of these experiences into my healthcare setting and into whether I can feel trust in healthcare. Throughout my pregnancy, I had a lot of difficulty. As I mentioned, my son has a rare genetic condition, and the end of my pregnancy was really traumatic. At 32 weeks, I had an ultrasound that showed a birth defect, kyphosis. I didn't know what that meant. The doctors couldn't tell me what that meant, but going through the process of getting an MRI and trying to figure out what was going on with him, they were never able to identify anything. They just had a NICU team ready when he was born. But none of my mental health needs were ever considered or managed or addressed during that time. And this is highly stressful. I was 35, having my first pregnancy that was going to term, and having a trauma that I was experiencing in real time. And no one used their words to support me in these situations. So a lot of this is why I got involved in healthcare advocacy, not because of trust, but because I wanted to see what was going on behind the scenes that was causing these kinds of experiences for other women. And as you see on the right side of this slide, I have communication skills. I have high education level and socioeconomic status. I have knowledge about healthcare. I have participation in healthcare. None of these protected me. Not one of these was a protective factor for me in my own journey. So I want you to remember there are patients coming before you who have much less protection than I have. I understand the privilege I bring into that space. And every time I have this kind of encounter, I think about the women who don't have that level of privilege, who don't have that level of self-advocacy, because I know their experiences have to be worse than mine. So I want to talk to you a little bit more about how we can think about patients and how to protect them from the bias they are inevitably experiencing, which shows up in the numbers. This is one of my favorite quotes. It's an Ikatina song, but I can't believe what you say because I see what you do. And when we talk about building trust with communities of color, building trust with communities that are hard to reach, it's hard to say to them, you should trust, right? We have this idea that they should trust because we're trusted community partners in healthcare, but we see those results. And it's not just about Tuskegee, right? It's not about something that happened 40 years ago. It's about these experiences we are having in our own healthcare that really change the level of trust we can feel in healthcare. So when we talk about building trust, we have to talk about that from a perspective of real life trauma happening to women in this lifetime, in their experiences, and in the experiences of their community members and family members that we're all hearing about and talking about. So let's think about the cost here. Do we even know it? We know that bias is going to change trust. And it also can change who we rely on for information. So this is a really important aspect of critical thinking. What's a reliable source of information for you? And if we have had trust destroyed in healthcare, we're gonna look for other sources of information, right? So when you say, well, the patient said she wanted to listen to what her grandma said, why? It's because trust has been destroyed in other areas. And so of course they're going to go to what is a reliable source for them. We've talked about continuity of care being ruined by a trust experience because no, I don't want to go back. No, I don't want an appointment because I've had a traumatic experience here. And then evading bias itself becomes a workload. If I want to find a provider of color, that can be very difficult. So then that's a workload for the patient to have to find that. Testing out new providers is always a crapshoot, right? Because then you go through, you try to build a relationship, maybe it doesn't work, then we have to break up, then I have to start all over again, you know? So these kinds of things change the continuity of care, and then they add to the workload of patients who are already experiencing trauma and bias. And finally, we see outcomes, but this is not just individual, it's collective. We're talking about whole communities who are experiencing these kinds of things in their communities and from their institutions that are supposed to be serving them. So our history is also the present. It's not just the past. So I really want to think about protecting patients from bias and how we move forward to use those words in more powerful ways and protect patients. Some of the principles I think we need to think about is that bias is not a character building activity. I think a lot of times it's approached like, we're going to build your personal character and we're going to, help you understand your biases. This is dangerous and it is killing people. And so it can't be addressed as a personal issue. It's a deficit in skill that is killing people. So we really have to think about bias much differently. And we can't say that some people get to participate and others don't have to. Everybody has to take action on this. No spectators allowed. One of the things that I advocate for at all times is really engaging patients and families in solution making. If you don't have the people at the table who are experiencing the problem, the solutions you come up with may be entirely irrelevant. So when we think about this, it can't just be, again, on this personal level, it has to be about policy as well. If we're not changing policy, we're not impacting equity really. So we have to find ways for patients to report bias when they experience it. We have to measure that, right? You can't tell me you're improving a thing you're not measuring. So if you are not measuring people's experience of bias and harm, you can't be improving that. You have to also tie it to quality, safety, experience. We all take numbers on that. We know how many falls we have. We know how many ventilator-associated infections we have. If we are not willing to measure bias in the same way, we're not looking to change it in the same way. And then show your work. I want to know what you as an institution are doing. I want to know what you as an individual are doing. Show me what you're doing to make this change. And that's what's going to help to build trust in your communities. So things you might want to know: when, where, and how often are your patients experiencing bias? Do they have a way to report it? What has it cost them in a personal sense? What has it cost your organization? And it may be monetary. It may have cost your organization money. What are you going to do to mitigate it? What are you doing and is it working? And then how are you engaging the populations experiencing the most harm? And this is one I want to sit with for a little bit, because patient and family engagement really can mitigate some of that harm. This is a panel, I'm giving you a visual of a panel I served on for CMS to measure maternal morbidity. The problem looks like Black women experience this problem 3 times more often than white women. I was the only Black woman on this panel. So to me, you are measuring something, or you are creating a solution without the people who are most impacted. A lot of times we think of representation as population statistics, but I would encourage you to start thinking of representation as who's experiencing the problem and how you're going to address it with that level of detail. So if someone's experiencing the problem 3 times more often, this panel should have looked very different. Because I, as the one Black woman on this panel, cannot represent the experiences of poor Black women, of rural Black women. I can't be all of that. You need them at the table. There are qualitative differences in the experiences we're having in healthcare, and having one Black woman at the table is not sufficient to solving those problems. So I want you to really think about the solution looking like the problem. And right now, a lot of the current state of patient engagement is that there's tokenism. So you do get your one Black lady on the panel, done, check the box. A lot of paternalism of telling people what the solution should be and assuming that their communities don't have solutions already, instead of gleaning solutions with the communities that are affected. A lot of times there's exploitation, equitable representation is not there, and really that undersampling. So I want us to think about who we're sampling and oversample when the problem is overly in one community. And finally, thinking about communities leading the solution-making process. Communities do have solutions. We have wealth of knowledge within our communities that we've been solving problems that other people have not been solving for us for a very long time. We need to help define the problem with communities, understand the scope of the problem with communities and engage them, and also compensate them for their expertise. I've often sat at tables where I'm the only person at that table not being paid for my expertise when I'm the one bringing lived experience. So this is something I want you to consider, because as you're coming up with plans and budgets, your budgets should include compensation of those with lived experiences as well. Some of those barriers, I want to talk about barriers and solutions kind of side by side. We often say that people are hard to reach, but really they're there. They're not hard to reach. You need to engage in partners in their communities that they trust to reach them. We often have those policies that don't support engagement, which would mean that we're having meetings during hospital hours versus hours when families are available, right? Or not providing the kinds of accommodations families need to actively participate in solution making, not compensating families. Sometimes we have a hard time finding the right patients. And because of my education level, I tend to be one of the right patients a lot of the time, right? So people want to hear from people who are articulate and who can stand up and talk about things. Those may not be the patients who are going to give you your best solutions. So who the right patient is something we should really consider when we're talking about engaging people. And then providing the right supports so that any family can be the right family, any patient can be the right patient. And then finally, if there are needs identified, one of the challenges I've often heard is we don't ask about social determinants of health because we don't have a solution for all of them. So we don't want to ask about something we can't solve. Instead, think about what you need to measure so you can help to find solutions with the community so that you can help to solve those things. But instead of giving up from the beginning, let's measure what we actually have in front of us. So those are really good ways, I think, to think about effective engagement of families and patients in the work that you're doing. I do want to give you a resource here. I work for Family Voices, which deals with a lot of children with special healthcare needs and their families. And we do have a tool that measures family engagement and systems change, including your commitment to family engagement and patient engagement, how transparent you are with communicating in that, what representation looks like, and then what the impact of your work is. And these are validated tools that you can find at familyvoices.org. But I just wanted to introduce you to that if you're looking for a way to start measuring. And none of the work you're doing today matters if your patients are experiencing harm. So I really want you to think about that all of the practices you put in place, all the plans you make, it all sounds great. But if your patients are experiencing harm in the healthcare they're receiving, it's going to change their experience entirely. And none of this matters if they are still being harmed. And that's all I've got. So I thank you all for your time today and your listening ears. Thank you.
Thank you very much. You guys were ahead of schedule. I can't believe that. So I am going to pop up. This is if we have any questions. If you guys want to go ahead and you can text in your questions throughout the day. If you guys have questions, I'm going to have Nikki stay up here for a few seconds and see if we have any questions. And if you have a loud voice and you don't want to like text it in, you can actually stand up and shout it out. So for everybody that might not have heard that, it's as nurses, she said, we're taught to actually put the quotes in. So is that something we should continue to do, or is it now that we should look at doing it differently? So I'll let Nikki answer that.
I would say you should still use your practices and put the quotes in, but check it. I mean, think again, is this unflattering to the patient for some reason? Is there a way to present this that does not demean the patient? As you saw, some of the quotes in there were ones that were kind of degrading and kind of mocking their grammar, maybe. You want to make sure you're not doing that, I would say. So I'd say if you're going to put in a quote, check the tone of that quote. Make sure that it's in there for a purpose, and that purpose is not to state a judgment.
Families, oh, can y'all not hear me? I've got a really big voice. Anyway, I think with parents having unlimited, unrestricted access to the charts, I feel like that we may actually be limited in what we can say because of fear of retaliation or going to the patient representatives. So I don't know, what are your thoughts on that?
I think that's a great question. One of the things that always helps me feel warm and fuzzy when I read a note is when you start with something personal that we discuss. So my son, I take him to his orthopedic doctor and she loves him. And she starts off his note, you know, Richie's a future astrophysicist and he's interested in race cars. So she starts with something that is relationship building. So I don't think that's a bad thing. I love having access to my records. It is my right to have access to my records. So again, this is a communication tool that we're going to have to keep working on and refining. So yes, you want to have your clinical notes in there and understand that. And I actually had a physician say to me, the clinical record is mine. And I said, no, it's mine. It's my information. So it's not yours. It's yours. It's a collaboration tool. So how can you think about this in a way that is collaborative? And I think that it can feel vulnerable, I'm sure, to write down all of these things. But I think that means that we have to be more thoughtful then, because this is another form of patient communication. I also advocate for plain language in the health record, because patients need to actually understand what they're reading in order to participate as equal partners in their care. So I think there are lots of considerations that can be made and built upon now that this is a thing that's happening, but making sure that patients and families understand what's in that record and then using it to build relationship is another opportunity here to have a positive connection with the patient.
We have one over here.
Where's the over here? I'm sorry. Oh, hi.
Right here.
Hello.
Hi, my name is Lindsay. I'm a pediatric resident at EVMS. I had a question if you had any, or you've been a part of any QI projects where patient advocacy that allowed like parents or patients to have their voice heard, and if you guys made any changes with that QI project?
Lots.
Okay.
I've been involved in a lot of work like that. Patient-centered rounds where there's a patient who's actually on the rounds, giving feedback to the physicians and the providers about how they talked to other patients. So that requires a great deal of trust and sometimes some work with your legal department to allow that to happen. It does. I've been involved in a lot of that type of work though, and they're running things by your patient and family councils, these kinds of things. Those are other ways to really involve patients and families. So I think the more you can integrate with the systems that exist in your organization, there may be patient and family councils, there may be patient-led groups. Any of that can help to improve, but I also think let those be patient-driven. So a lot of times we want to come in with an initiative and say, this is what we want to change, but ask what they need and ask the right patients. When we talk about the right patients, that might not look like what you think it's going to look like. But I do think that I know I've seen improvements in the conversations based on that. I've seen improvements in the way that providers regard patient input. And that alone can be an improved outcome to understand and raise the regard for patient input, which opens up new opportunities across an organization as well. And I have one on the poll, EV, that says, do you have any recommendations on validated tools for measuring bias in your unit? I think that if you're looking at any of those data sets and you look at them by different categories, whether that's race, ethnicity, whether that's LGBTQ, all of those different identities, I think these are ways that you can look at data. So a lot of it's how you're going to sort and parse your data and what you're going to look at when you do that. And I think that opens up a lot of opportunities, but I don't know any specific validated tools for just measuring bias. I think what you're going to find is you're going to measure different outcomes, and those outcomes will show you where your bias might exist as well. So that can point you to that.
Do you have another one up there?
Yes, I do, but
okay.
I'll take this one first.
Okay.
Yes.
So mine's gonna be kind of an opposite of yours. As if I categorize myself, I'm an older white woman, white hair, brown pre-COVID. So in dealing with populations that I am not like them, definitely I got from your talk, not being parental, telling them what they need, asking collaborative. What other ways, as I look to work with women in prison and some disparities in our area, we've got some other pockets that we're identifying with the Latino population. Mm-hmm. What would be your advice to me to meet with them, there to help? But obviously I'm not going to be any of those things.
Yes.
What would be your advice?
Well, the reality is that the differences in population and healthcare means that we're not always going to find a provider that looks like us. And we know that. I know when I'm being treated like a human being. I know when I'm being regarded and listened to like a human being, and that alone is very important. So opening the conversation with the idea of cultural humility. I don't know everything about you. I want to learn about you. Curiosity, I think, is the opposite of judgment, right? And so if you can approach with curiosity to find out what people's needs are, this is just a very human activity at its essence. And sometimes that's what we get out of in healthcare, is that everything's about numbers and processes and in bundles, but we lose the human touch. And I think the more you can just be eye to eye with somebody and say, I want to understand what your needs are, that matters. I don't think all my providers need to look like me. It does help with trust sometimes, but I've had providers of color who also were not great providers to me and who also came in with bias and judgment. So this is not something that's just based on who you are. It's based on how you approach people. And so I think if you're approaching, first of all, you asking that question says to me that that matters to you. So that's important. And I think that when you're in that space with people, just coming down to that human to human level of connection is essential. I hear, how do we do this in the limited time that we have in with our patients? That's a question I hear a lot. Eye-to-eye contact is really a great thing. Don't type at me the whole time, please. I think that's one key thing. Can you come to eye level? Can you just take a few seconds? It doesn't have to take longer to make a connection. It just has to be something that's very conscious and intentional. And so I think that even in the time that you have, you could do that. I also think there are opportunities to say, maybe we need an extended appointment. And that's a thing that I will ask for if I feel like I need more conversation. But I think most patients don't know they can ask for that. So that's another thing to tell your patients is that if you feel like you need more time, we can have more time. So I think that limited time is something that, yes, the structure of the system does promote, but I also think there are ways to work around that and still ways to connect in the limited time. And I see here, you said they started to implement doula services for Medicaid patients. Okay. Oh, I think this one might not be for me. About being able to afford doula services. So I'm going to leave this here because this one might not be for me. Okay. Thank you. Oh, yes.
Hi. Good morning. My name is Eliza Holland. I'm one of the pediatric hospitalists at UVA. Thank you so much for sharing your story and really bringing a personal touch to all of this. This isn't so much a question as a statement. We're really working hard on the pediatric floor at UVA to do family-centered rounds, which is something that is very difficult for the medical students and the residents to wrap their head around, especially after they've been on other services where they want very focused, detailed, we're going to run in, we're going to run out. And it's very uncomfortable. I love it. And I've been doing it for a long time, but it's, we're trying to teach them to have a conversation with the family and start off just, how are things going? This is what we're seeing. Does it agree with what you're seeing? This is what we'd like to do today. How does that sound to you? Yeah. And I hope, I don't get a lot of feedback from the families about it. I hope that it makes things better for them. We also work a lot on explaining, not dumbing it down so much, but remembering that probably when you're giving reading material, I say gear it towards 3rd to 5th grade level. So when you're giving medical information, really break it down into simple terms, remembering that families hear what we have to say probably 33% on the first pass. So repeating. And it's really hard. Our medical system is not set up to teach people how to talk like that. Yeah. We spend a lot of time teaching very detailed medical language. And then when they get to us on the pediatric floor, we're like, scrap it all. So anyway, if you have any feedback on that or any other suggestions about things we could be doing better.
I do. Yes, I've done a lot of this. I've worked, one of my roles has been on the board of directors for Rainbow Babies and Children's Hospital in Cleveland. And I was the president of the Patient and Family Council for some years there, served on the Quality and Safety Committee. So I've done a lot of that kind of work of rounding. And there's nothing more terrifying to a family than what we call the white wall. You're sitting there and then all of a sudden this wall of people come in and it feels official, right? It's very terrifying. It can be, especially if you don't know the language. And so I advocate for health literacy universal precautions, which is a way of communicating at a clear level with all families. And I think that sounds like what you're working toward. Health literacy is my jam. So making sure that you're communicating in simple terms. I love that 3rd to 5th grade level. And I do see that the shift from using medical language to using simple language with families can be very difficult for new residents and all of that. But it is really essential to helping them understand. One of the first things that actually got me involved in healthcare advocacy was being in the NICU with my son and getting this packet of paper and having had 2 degrees in English and having to double read these things. I was like, this is not right that I'm having to read this twice. My degree is in literary analysis. I should not have to use that in a hospital setting to understand the materials that are in front of me. So really understanding that the material that came in front of us was so difficult. One of the things that I did leading the Patient and Family Council at Rainbow was we had a review committee for materials that people could send through us to have us help revise that to plain language. And I very firmly believe in plain language as a tool. It's one of those tools that helps you achieve health literacy, and health literacy is under the umbrella of health equity. So all of these things relate to each other. And again, families cannot be equal partners in decision-making if they can't understand the information. So I think the start that you have there sounds excellent, and really training them on how to talk to families is so important, because none of the information and material you give me matters if I don't have the capacity to understand in that moment. And one of the key things that we should all know about health literacy is variable. So you don't come in because you have a doctorate in something and your health literacy is automatically, at a 10. You can come in and have an emotionally charged situation and understand nothing else that happens in that conversation. And this is how health literacy works. It's so variable that we always have to plan for the fact that people may not understand in an emotionally charged moment what's being put in front of them. So I think it's important to reinforce that in multiple modes, to realize that written language is not the key way to explain things to everyone. So how do we explain things to people for whom literacy is not a strength? And then also, how do we reinforce the material and information we give? How do we actually, teach with them and help them learn? So I think it sounds like you all are on a great track for building those skills, but that learning together process and helping families not feel judged for not knowing is really important too. Thank you.
Thank you so much, Nikki. All right, we're still slightly ahead of schedule. How's everybody feeling? You guys need to stand up. Stand up. We're ahead of schedule, 8 minutes. And I think there was somebody, and I'm not calling anybody out, but we have some tables up in the front that have seats if you need a table. We have 2 back there. We're not taking a full break. We're just standing up and stretching because we're going to move right into Brittany. We have some tables up here. All right, so that was a little 2-minute break. Hopefully everybody's feeling a little bit more rejuvenated. So our next presenter is actually going to be joining us virtually from CDC. So I want to introduce Brittany. She is a health communication specialist from the CDC Division of Reproductive Health. So without further ado, thank you for joining us, Brittany. I'm going to delay a few more seconds, Brittany, because everybody's trying to find their seat after that 2-minute break.
Sounds good. It's a pleasure to be here today from Atlanta.
All right. Go ahead, Brittany. Thank you.
Thank you. Well, good morning, everyone. It's really, really a pleasure to be here today. Thank you so much for the opportunity to chat a little bit. I'm going to be talking a little about CDC's National Communication Campaign that is seeking to address maternal mortality. And just listening this morning, this should fit very nicely into the previous speakers and what we're all talking about today. So let me just start with a quick agenda. Basically, I'm going to chat with you a little bit about this Hear Her campaign, what materials are available, and hopefully share some ideas about how you guys can use materials and resources, and provide some examples of how some local groups have been implementing them, and sharing some stories of the impact that they've been having. And then happy to take questions and really hear feedback about what you guys think and how we can do things better moving forward. So to start us off, I'd love to just show this 1-minute video. It kind of gives you a feel of our campaign and the messages. I shared audio, so hopefully you'll be able to hear it. And I think it'll just set up our conversation well.
He's the one who noticed his mom's face was swollen. They're the ones she confided in about her change in vision and headache that wouldn't go away. He's the one who really listened when she said that something just didn't feel right. When she had chest pains a few weeks after delivery, she's the one who insisted on admitting her to the hospital. Too many women die from pregnancy-related complications each year in the U.S. Death can occur during and up to a year after pregnancy. It doesn't have to be that way. Most deaths are preventable. Know the warning signs, hear her concerns. You could help save her life. Learn more at cdc.gov/hearher.
All right, so the Hear Her campaign really is seeking to raise awareness of the urgent maternal warning signs that people can experience during and within the year after pregnancy. And we're also trying to encourage the support systems, healthcare professionals, of anyone who interacts with pregnant and postpartum people to really listen, when they express concerns. And so our primary audiences that we're talking about here are, pregnant and postpartum people and their support networks, including partners, spouses, family, friends, doulas, anyone in their community who may be supporting them. We have a special focus on reaching Black, American Indian, and Alaska Native people and their support systems because they're so disproportionately affected by maternal mortality. And we're also trying to reach healthcare professionals who interact with pregnant and postpartum people. So this might be obstetrics, but also, emergency medicine, urgent care, primary care, even pediatrics who, see new moms at those infant well checks, and especially providers who serve disproportionately impacted populations are a key group that we're trying to reach. So again, these are kind of the campaign objectives, really raising awareness of those urgent maternal warning signs that could really indicate a serious life-threatening complication. They require immediate medical attention. We want to empower people to speak up when they have a concern, but importantly, we want them to know that they will be heard when they speak up. So those support systems, engaging in conversations, not just dismissing that, oh, of course you're pregnant, you're supposed to be tired, or of course you're swollen, but really taking the time to talk to her about those concerns she's having, get her immediate medical care, and providing tools for patients and providers to better engage in those life-saving conversations. So today, I want to focus on these last two, which is, a role of all those who work in perinatal health. So healthcare professionals, community health workers, doulas, and really anyone in the community who's supporting birthing people and their families. So kind of our overarching messages that guide this work, which you've already heard today, and these are not, crazy, new novel ideas, but they really are the core of what we're trying to do with this campaign. The idea that people who are pregnant and recently pregnant know their bodies. They know when something is not right often. And we know that listening and just taking those concerns seriously is simple, yet it's really powerful in preventing pregnancy-related deaths. So new CDC data came out that shows more than 80% of pregnancy-related deaths are preventable. So we're trying to do what we can to really reduce deaths that could be prevented, and listening is one of those steps. Having an accurate diagnosis, timely treatment, quality care can prevent a lot of these deaths. And so we're trying to get to that point of getting quick diagnoses, the right treatment, and the right care. And so we know that partners, friends, and family, they're all important advocates to make sure health concerns are addressed appropriately by a healthcare professional, and really just this positive tone that we all have a role to play. So everyone has a role to play in preventing pregnancy-related deaths. So when we're talking to community members, healthcare professionals, whoever you are, there's something positive we can do to, move the needle in the right direction. So I really just can't overemphasize the role, healthcare professionals and community health workers play in educating, supporting people who are pregnant and postpartum. And I do want to emphasize, that pregnancy-related complications can happen in that year after pregnancy. Many people aren't interacting with the healthcare system as much during that time. And in fact, recent data from our maternal mortality review committees in 36 states found that more than half of the pregnancy-related deaths were occurring after pregnancy, about 53%. So again, there's a role we can all play during this time to make sure people are getting the care they need. So I want to talk a little bit about some of the campaign resources and materials that you may be able to use in your communities and with your clients and patients. So I'll kind of run through some of these, but the resources we have available is the website at cdc.gov/hearher. We have this website in English and Spanish. We have the content on the website available as microsite. So it's embeddable code that you can actually place the website on your website. And as we update information, it will automatically be syndicated and updated wherever it's embedded. A key piece of our campaign is video testimonials. So really hearing from women who experienced pregnancy-related complications and how they may or may not have felt heard and kind of the experience they had. We have printable resources, some in more than 20 languages that include conversation guides, palm cards, posters of the urgent maternal warning signs. We also have several digital graphics and media ads that you can download and use, a social media toolkit. We also have a Hear Her Facebook page, which kind of serves as a community engagement opportunity for people on Facebook to talk about their experiences and learn information about when to seek care. We also have public service announcements that you're welcome to use and send into radio stations for local placements. And then MAT articles, which often local news papers or online news outlets will use just as they are and kind of submit that way. So let me chat a little bit more about some of these. So again, the cdc.gov/hearher website has a lot of information about pregnancy-related deaths, how they can be prevented, and specific information for, pregnant and postpartum people, those who support pregnant and postpartum people, and healthcare professionals. So a variety of information and resources. I'd love for you to check out the website when you have some time. These compelling stories, I won't play another video right now, but, people who've had experiences with severe complications or conditions and kind of how they got help. And so I'd encourage you to check back at some point to listen to some of these stories. We're in the process of developing additional ones, some that will support or feature the support systems, whether it's a spouse or a sister, and how they really encourage the person to get care. And we have also testimonial videos from healthcare providers that we'll be releasing that kind of share their experience and kind of how they face implicit bias and what they do in their practice to try to make sure they're providing culturally appropriate, respectful care every time. And just with the understanding, no one's perfect. We all have these, implicit biases, and how do we overcome them? And how do we make sure our place of work, is conducive for people sharing concerns and listening and opening up? So I'm really excited to have some additional videos come out soon. These microsites and content syndication is really neat. You can embed code. So a lot of organizations have just plot this information on their website. So, your users don't leave your website, but they can still see the Hear Her content. And so there's some ways to embed it. You can even choose which color works best for your website. So if that's something you're interested in, I encourage you to check out the page and look at how you can do that. So again, as the content's updated on CDC's page, it would automatically get updated on your page. I would like to note, we're really excited to have several of our downloadable materials in 21 different languages. And so if you serve a population that speaks one of these languages, would really encourage you to check out the resources. And they are downloadable. And we do have the opportunity to order English and Spanish resources at no cost through our CDC Info program. I'll talk more about that in just a second, but I want to share, this is one of our most popular materials. So these highlight 15 urgent maternal warning signs that really require medical care right away if a pregnant or postpartum person experiences them. So we collaborated with the former Council on Patient Safety in Women's Healthcare, and that council had an expert committee that basically came up with these 15 warning signs that really require immediate care. So this has just been a very popular poster. This is one of those resources we have in a number of languages, probably about 20 languages. So we have it in a few different sizes. That has been really helpful as printouts and just handouts to give to people who are pregnant or at discharge or were recently pregnant. These palm cards are really 5x7 guides, and they have the list of urgent maternal warning signs, and they also have tips for talking about concerns with healthcare providers. So we have one for pregnant and postpartum people, and then we have another one for their support system. So the partners, husbands, friends, family, caregivers on tips for how to listen and act quickly when their loved one says something doesn't feel right. So these are materials we do have available at no cost to order. It will get mailed to you if you'd like. And so there's a link through CDC Info on demand publications. And then there's also a phone number you can call if you need to order them. So again, these are the 5x7 guides. And then we also have a larger form of the same guide, again, both for pregnant and postpartum people and their support system. So these can be used as handouts to distribute to patients or people you serve in the community. Again, just a really nice way to have all the warning signs and have some tips for starting that conversation, tips for how to share what you're concerned about, how long you've been having a symptom, how serious it feels to you, just to help kind of advocate for yourself or your loved one. We do have a variety of graphics and sample social media posts that you are more than welcome to use through your organization or personal channels. So there's kind of a whole social media toolkit on the website where you can take sample text or graphics and download it and share it. So this is all public domain. They are free to be used, free to be shared. We know no one wants to reinvent the wheel. And so we've been really fortunate. A lot of state health departments have been really interested and working with us and using some of these materials because the Hear Her concept really resonates. We've had a lot of positive feedback and people just really appreciate kind of the message and what we're trying to do. So feel free to use these as you see fit. I'd also like to note, we have materials designed for healthcare professionals. So we have messages around the importance of listening, that's really one of your most important tools. And we have materials for those not in obstetrics. So, for emergency medicine or urgent care or primary care, just this key question to ask to make sure ask if your patient is pregnant or was recently pregnant, because that's not always something that's immediately identified, potentially in an emergency setting. Maybe the patient was pregnant 6 weeks ago, but that's not always the first thing asked. So we have some materials around the importance of asking that question and that there's physiologic changes. And so a high blood pressure of some number may not mean a lot to an emergency doctor, but if that patient was postpartum, that raises the red flag that it may be more serious and it could be postpartum preeclampsia. We recently put out a Medscape case challenge that talks about that very issue where a patient presents to the emergency room, had high blood pressure, had headaches, and it wasn't kind of determined for a while that it was related to their recent pregnancy. So I encourage you to check that out if you're interested, a Medscape case challenge. And then also, some materials for pediatric staff around mom's health and just the opportunity to ask mom questions when they're in the infant well checks, how are they doing, mental health, physical health, and just trying to connect to care, if needed, whether that's connecting to support services or connecting to emergency medicine, or just, being a start to a conversation, encouraging her to go to those postpartum visits as well. So we are going to be working to identify more ways to reach more specific audiences, such as nurse midwives, obstetric nurses, doulas, and community health workers in this next few months to year of the campaign. Those are some audiences we're really going to be trying to reach more. So I encourage you to take a look. Some of these materials may be helpful in your place of work with your staff. We have links for more clinical tools and resources. There's a lot out there, not just through CDC, but a lot of other organizations who have some great, implicit bias trainings, cultural humility trainings. So we try to link to a lot of those resources. So I'd love to just share, these are some ideas, some examples of ways that you may be interested in using or sharing the campaign materials. You probably have your own ideas as well, but you could certainly send information about this campaign or really the messages through newsletters and listservs, websites. You may have a leadership blog or social media or other digital platforms. You can disseminate materials through meetings or presentations. There may be exhibits or health fairs. There might be in-person events or virtual events that you can, print materials. You can send this out. And again, I'm sure you can think of additional ideas, in your particular settings where you can share with healthcare staff, pregnant or postpartum patients, community members, and again, anyone who really supports birthing people. So let me share a couple of examples just to get the wheels turning a little bit. We recently heard about the Greater Newark Healthcare Coalition and the Partnership for Maternal and Child Health. They developed a webpage called newarkmom.org, and they house a lot of the Hear Her materials on that webpage. And so they actually worked with a creative agency to run a digital ad campaign that pointed back to this local website. And so they ran that from May through September of 2022, so just this year. And there's an opportunity, especially state and local health departments and some nonprofits can go through a resource that we have called the State and Community Media Resource Center, and they will help localize our existing Hear Her ads with your logos, while also still citing CDC as the source. So you see here on this page, you have the Hear Her logo, you have the Greater Newark Healthcare Coalition and Partner for Maternal and Child Health logos on the bottom, and then the source cdc.gov/hearher at the bottom. And you'll see in the middle, they have an ad where they used local Hear Her ambassadors as part of their creative. And so the First Lady of Newark is pictured here. And then on the right, that's Olympic track and field athlete and star Allison Felix, who was and is a spokesperson for the Hear Her campaign and has been an ambassador for maternal health for several years. So this particular ad campaign they ran received about 1.6 million impressions, which are just how many times an advertisement is seen. And it led to about 16,000 clicks back to the newarkmom.org website. So that's just one opportunity, if your organization had resources to use for like a local ad campaign. Other states like New York has done similar things, Tennessee. If you're interested in other examples, happy to chat more about that later. I also wanted to share this example. The National Healthy Start Association, through a HRSA cooperative agreement, developed community-based bundles called the Alliance for Innovation in Maternal Health Community Collaboration Initiative, or AIMCC. And Strong Beginnings is a federal Healthy Start project in Michigan. They are one of 6 pilot sites implementing these bundles. And so Strong Beginnings chose to use the Hear Her campaign materials to educate birthing persons on the urgent maternal warning signs as part of their postpartum bundle from 2021 to 2022. So I got permission from the project director to share some of this information, but they basically provided several trainings to 350 to 400 providers and home visitors in the use of Hear Her. They had local hospital systems use Hear Her at their obstetric intake, hospital discharge, and postpartum visits. They have some special education sessions for male partners, and they use our support system materials in those education sessions. They have a monthly Manhood Monday Facebook Live that reaches more than 800 men throughout the month. They also have Fathering in 15 Fridays, which are attended by about 60 men each week, and a monthly Strong Fathers newsletter. So we thought that was a great way to reach, spouses and partners. And then the Michigan Department of Health and Human Services sent here her links to all their home visiting programs statewide. So, they would say that one of their lessons learned was that adopting here her materials was efficient and readily accepted by the community stakeholders and clients. So some positive feedback if you're interested in using it in a similar way. And kind of to end our time, I do want to share a few kind of personal stories of impact, which is really meaningful to me and to our team, because we know that the materials are resonating, but to really see examples of where it makes a real impact. The Strong Beginnings organization that I just shared had shared a few of these examples and gave us permission to share, but basically this was a quote from someone who had a I won't read it all to you, but basically had seen the Hear Her materials, was more aware of the warning signs, and caught preeclampsia much earlier in her second pregnancy than she would have otherwise. And so she said she was able to get the treatment she needed and was much more involved in the decisions with her care. And she was able to advocate for herself better and describe her symptoms in a way that got the healthcare professionals to listen to her. So that is just what it's all about. That's why we're doing this. And so if people can actually get treatment and care sooner or be listened to, that is what it's all about. So really just happy to share that. And then one other example was a perspective of a community health worker supporting one of their clients. And so they had reminded the doctor, this community health worker, that we want to be sure we're hearing her when talking to the nurse. And they had a three-way call together to talk about the patient's concerns, reminded the nurse about the Hear Her campaign, and the client, expressed thanks for their advocacy. And so I think, this ended up being okay, but the client really felt more heard and felt listened to and felt advocated for. So these examples just help remind me, how important these messages are. So I just want to really thank you for the opportunity to share today on ways we can work together to extend the reach of this campaign and these materials, much further than we could alone. So I will just end with some of these resources to stay connected. Encourage you to check out the Facebook page, the CDC Hear Her Facebook page. You can also check out our Twitter account, CDC_DRH, which stands for the Division of Reproductive Health. And then we have this mailbox here at cdc.gov. You can always reach out to me, Brittany Behm, bbehm@cdc.gov. And we also have a quarterly listserv. So about 4 times a year, we'll send out an update on new materials Hear Her has. So if you'd like to be on that listserv, feel free to shoot me a note or email that Hear Her box. And really, we are always looking for feedback and input on how the materials resonate, what you think we could do differently, or what new materials we could use. So really open to feedback as well. So I'll end there and take any questions you have.
Thank you, Brittany. So for this one, if you guys, for ease, if you can chat in any questions that you have for Brittany. So Brittany, we have, I've searched the CDC source to cite for the new data that more than 80% of pregnancy related deaths are preventable. Where can I find that?
Yes. If you go to cdc.gov/reproductive health, I would go there, and one of the first links at the top of the page would be new data brief from 36 maternal mortality review committees. That's where you'll find it. Happy to send a link if I can, but cdc.gov/reproductive health. Yeah, it was released just in late September, I believe. So it has kind of the newest, best data on preventability of deaths, also the timing of when pregnancy-related deaths occur, and some of those leading causes of deaths, including mental health conditions and kind of the breakdown between race, ethnicity.
Any other questions? All right, I'm seeing none. Thank you again, Brittany, for being with us today.
Yeah, absolutely. And I encourage anyone, if you think of something later or have questions later, feel free to email us at hearher@cdc.gov. Thanks so much.
Thank you. All right, you guys, we're continuing to be ahead of schedule. This is a good feeling. So with saying that, you all get about a 25-minute break. So real quick, before we run to break, I want to just really quickly bring everybody back to the agenda because things are going to get a little crazy here for a second. So eliminating bias in the Dyad care will be in this room at 10:30. And then Project Empower Heartbeats will be right on the other side of this wall. So you go out that door and then right in that other door at 10:30. The presentations will be about 45 minutes. Then there will be 10 minutes for everybody to change rooms, run to the bathroom, grab something to drink. And then at 11:25 back in this room, we will have Women Veterans Program. Project Empower Heartbeats will remain there. And then we will have Eliminating Bias. So if you miss it the first time, it will replay. And that will be in that corner room right there. Then after that presentation is over with, or those presentations are over with, we will break for lunch from 12:10 and then be back seated in this room at 1:20. So food is actually behind me. So it's a big square. It'd be a lot easier if we could just cut through the walls. So you're going to go back out here. You're going to go all the way around, and it's in this room right here. And it is a buffet style lunch. And I believe there's extra seating room if you don't want to eat back in here, or you can come back in here to eat it. Or I don't know what the weather is outside. You can go outside, but you have options. You don't have to stay in this room, but be back in this room, everybody, please, at 1:20. The one other thing I want to say is some of you may have gotten orange surprise you won in your folder. Please make sure you see registration like during lunch breaks, because after that, I'm going to go count how many incentives we have to still give out. And then I'm going to start giving prizes out to everybody. So please, if you've won, collect your prize by lunch. And then if not, we'll come back in here and see what happens at 1:20. Thank you, everybody. Okay, if everybody can take a seat, we have an excellent presentation. All right, good morning. I hope everybody had a chance to move their legs and get a little bit extended break. So I want to introduce, we actually have co-speakers with this one, but I want to introduce Dr. Eliza Holland. She is our pediatric side of this project. So we have co-chairs, and then Arthur was originally, Dr. Ollendorff was originally the co-chair before he stepped up into the VNPC co-chair lead. So he, for right now, is going to still maintain this project in working with Dr. Holland. So without further ado, I want to introduce Dr. Eliza Holland and to hear about the Eliminating Bias in Dyad Care QI project.
Thank you. So I'm really excited about this project. In my work at UVA with Dr. Santina Zanelli and a really great group, we've been working on our NAS care over the past few years. And I do want to say a huge thank you to Dr. Zanelli for the first couple of slides. We've been doing some presentations together. Some of you may have attended the echo sessions we did on Eat, Sleep, Console. If you did, I'm sorry. Some of this is going to be a repeat. But so why are we doing this project? I think as you guys all know, there's a huge opioid epidemic right now that was stabilizing, but is getting worse. And you can see in these slides that between 2019 and 2020, there's been an increase in opioids, especially synthetic opioids. And the synthetic opioids have really been driving this crisis over the past few years. That's getting worse. And then the COVID-19 pandemic just made everything much, much worse. And you can see that in this slide here with the synthetic opioid deaths in the red and all other opioid deaths in the light blue. And if you look at this, there was actually, it looks like a stabilization on deaths between 2017 up to kind of early 2019, and then they started to climb. And then over the end, when we get into the pandemic years, you can see a sharp increase. What we know is that men are more likely to die from prescription drug overdoses than women. However, overdoses from opioids are increasing at a faster rate in women, and women are about twice as likely to be prescribed opioids compared to men. So what does this look like in pregnancy? Well, the number of pregnant women who are using opioids is increasing. Changed. And this is just looking at 2010 to 2017. The data has been slow to update. But if you look just at that time period, the number of women who were taking opioids at delivery increased by 131%. About 7% of women at this time point reported that they were using opioids during pregnancy, and 1 in 5 of those were a misuse, not just prescribed. So these charts look at the change in neonatal abstinence syndrome as well as opioid use during pregnancy from 2010 to 2017. And the darker the red, the higher the increase in percentages. The top maps look at neonatal abstinence syndrome. And the average rate in the US was 7.3 per 1,000 births. And you can see that West Virginia was leading that in 2017 with 53.5 per 1,000 live births. And then if you look at the increase over to the right, there was an 82% increase over that 7-year period in a diagnosis of neonatal abstinence syndrome. And Oklahoma and West Virginia were the leading states. The bottom maps are looking at maternal opioid related diagnoses per 1,000 deliveries. And again, over in 2017, that was 8.2 per 1,000. Actually, Vermont leading. And then, as we said, it was 131% increase in that diagnosis between 2010 and 2017, with Arizona being leader. So this data is actually from 2019. And the national rate of NAS was 6.3 per 1,000. Virginia was close to that with 7.1, and West Virginia was the highest with 44.1 per 1,000. And then this map, sorry, jumping ahead, is from Virginia looking at 2020. There was a little bit of a decrease in opioid use between 2019 and 2020, which has since been completely obliterated in the past couple of years. And the point of this map is not so much the overall neonatal abstinence syndrome rate, but just looking at the areas where it's highest. So the darker the blue, the higher the rates of neonatal abstinence syndrome. So not surprisingly, this disproportionately affects rural and suburban areas. And I say that because I think that just falls in line with what we're seeing in our own practice and where our patients are referred from. And it was actually pretty similar up through 2008, 2009. And then around 2010, it really started to diverge and become more of a rural problem. Not to say it doesn't happen in urban areas. And then this is the most recent data from that beautiful dashboard that Shannon showed us all earlier. So this is looking at a maternal diagnosis of drug use disorder in Virginia, going back 5 years. And again, the numbers bear out. Sorry, this is a really twitchy dashboard or touchscreen. The numbers in 2019 actually looked a little better than the numbers in 2018 when you break them out by quarter. And then we started to see an increase again in 2020, and then another increase in 2021. So what do we do? In 2018, the Virginia State Legislature actually passed a bill that created a multidisciplinary collaborative to better address the needs of families impacted by substance use disorder, which is why we're here today. And our specific collaborative is called Eliminating Bias in the Dyad Care, EBDC, if you want to break it down into initials. So the basis of this is some of what we've already been talking about, making sure that we have plans of safe care for our families, making sure that we're giving all of this care with a careful look at inclusion and equity, and that we're treating all of our families the same, and making sure that we're taking social drivers of health into account when we're making decisions and when we're making plans with families. And then the pillars are screening, data, coordination, education, and communication. So we're developing modules for every step in the prenatal through postnatal time period. And we are taking each of the pillars and each of the bases into account with these modules. So what does that look like? Preconception. We're trying to partner with methadone clinics or addiction clinics for preconception counseling, discussions about contraceptive. Once women are pregnant, how do we use the best practices for screening and referral in the outpatient? How do we develop good plans of care for these mothers around the delivery? How are we screening these women when they're coming in to deliver their babies? Are we doing it in an equitable fashion? Are we doing it so that we're picking up everyone who needs to be picked up? How are we communicating? Are we giving a clear message and a compassionate message? Around delivery, how are we managing these moms with an eye towards their opioid dependence? In that postpartum period, how are we managing the babies and making sure that they're getting the best care and that the families are involved and that moms can be at the bedside? And then in that postpartum, post-discharge, are we doing the best job transitioning these families to the outpatient world and making sure that they have adequate follow-up and that they have the care that they need? So our overarching objectives is that, number one, that we have plans of safe care that are made in a timely fashion and that are shared with the providers that are going to be seeing these families throughout their journey. So including the pediatricians, including outpatient providers, including families when appropriate. And the families are receiving equal, inclusive, and unbiased treatment, that we're really taking these social drivers of health into consideration, and that we're making sure that the families have the support in place so that they are able to succeed once they go home. Clear and consistent communication between families and providers, so we're all using the same message, and it's in patient-friendly terms. And ideally that all providers have been trained in the screening, brief intervention, and referral to treatment model for substance abuse, mental illness, domestic violence, and trauma at the start of care and throughout care, so that we're really able to relate and unearth issues that may not be apparent at the onset. So this is just an example of what a module might look like. So the coordination objective is that mother and baby are linked to substance use disorder treatment center. Medications are prescribed to the infant at discharge and they're available after discharge. So the coordination metric, Are the medications filled prior to discharge? Yes or no? Are the mother and baby connected with the substance use treatment center? Yes or no? So our diversity activity would be to procure options for inpatient recovery that allow newborns to stay as well, if that's a possibility. Plan of safe care activity that the providers at the treatment center have been involved and are aware of everything that happened up until the point when the family reaches the treatment center. And that mom is able to get the medications for the infant. Oh, I'm sorry. And then making sure that mom's able to get to the treatment center and at that time get the medications for the infant. So activities would include educating mom on filling prescriptions. How can she access them? Why is it important for the baby to go home on these medications? Referrals made to community service boards when needed. That the mom and the baby have safe housing and that they have reliable transportation if they're not admitted somewhere inpatient. That we have good case management services that are available at the hospitals, especially rural facilities, 7 days a week to facilitate discharge plans as needed. And we understand that some of these are very, very lofty goals. And I just want to say that all of the modules that we have set out are customizable. Like, we want you to take the information that is best for your facility or your area and use that. And these are just guidelines for things that you could put into place. All right, so Dr. Ollendorff is going to take over the pregnancy.
I'm not taking over all of pregnancy, I promise you. So we're excited about this project, and I'm going to, I'll be really honest. I'm bringing some biases. I helped start the program in North Carolina, the QI project. We learned a ton. We learned a ton when you start a QI project, especially when you realize it's we called it EBDC for a reason. We realized that the bias, and we've heard a lot about bias today, but the bias in the substance use disorder, especially in the pregnant substance use disorder population, is massive. And it's actually a huge barrier to care across the continuum, because it's really obvious that there is no neonatal abstinence syndrome, but they're not substance exposed moms, right? That's pretty clear. But the hard thing when I talk to Eliza and I talk to other pediatric providers, it's really hard to know if a baby has neonatal abstinence syndrome or they're just jittery or they're just having a bad day. They just want to be held. So we have to have that history of substance exposure to make the diagnosis of neonatal abstinence so we can actually do the right care and pick things up. And that sounds so easy until you actually look into it. And this is a little bit of another bias of perinatal quality collaborators have been very hospital focused traditionally. This project has a hospital focus, but the vast majority of this project is going to be outside the hospital. It's how do you link with communities? How do you link with patients? How do you get patients in the right place? How do you do these screenings really ahead of anticipated delivery? So one of the things I have learned now taking care of formerly of women with opioid use disorder, both in North Carolina, a place called Project Care in Asheville, where I used to live, and now in Project Emerald in Roanoke, is that there are incredible barriers for women to divulge their substance use disorder. Sometimes pregnancy is a great time and they're excited to, I'm going to do something for my baby. I'm doing it rather than for myself, but there's a huge amount of guilt. And I can tell you the first thing when I do a new consult for someone that's perinatal substance use, we sit down and I go, hey, first thing, elephant in the room, we will eventually talk about family services. Like, oh, thank you. I was afraid to ask. Like, yes, that's the elephant in the room. Or you can take my baby from me. Like, and I don't have that control, but I can tell you, let's work together. And I think we're in a much better place. There's obviously concerns about what have I done to my baby? As I've learned more about, I prescribe Suboxone or Subutex or people are on methadone, it's hard to realize that it's not a dose dependent relationship. You can be on a small amount of roxicodone because that's what you like to use, or you could be on methadone dose, and your chance of your baby having NAS is not dependent on dose or route or amount of what you take, which is a really hard thing for patients to understand. Like, I want to cut down to the lowest possible dose, not a bad idea. That's not going to say your baby's not going to have NAS, and that's a hard thing for people to get around. And then obviously, will it take my baby away from me? And the bias is real, and it's hard. It's hard for people to talk about, to their families. It's hard for people to admit that something is going on, and we have to make it easier. So the recommended approach sounds really simple, right? But I can tell you something I've learned about screening, especially in the perinatal population as an obstetrician. People don't like screening for things they can't fix. So IPV is a great example. I worked in probably the most progressive practice I could ever imagine in Asheville, North Carolina. If you all know Asheville, Asheville has a reputation for a reason. We were afraid to screen for IPV because what happens if they say yes? Well, it's good, but yeah, we need to have resources. It's very similar in the opioid use disorder world. People will scream, but then what do you do? In small communities, I know in Roanoke, like, hey, you call Kim Simcox, or now you kind of call me. She will help, and we're there kind of 24/7. That's kind of a resource. It's not a great resource, and it's just really hard. So we try to talk about screening a lot because screening is really important. We don't know if a woman has a substance use disorder problem. We can't try to help treatment. We can't try to help recovery. We can't try to coordinate care. A lot of this is coordinating care. Illinois spent a lot of time coordinating care. They would say if someone screened positive or you had a history of substance use disorder, you should treat like a medical problem. If they had diabetes, you wouldn't say, oh yeah, we'll take care of your diabetes when you get to the hospital. No, you'd have a plan of care. You do things. Substance use disorder is no different. It is a condition, you treat it. So we screen. So screening sounds really simple, and you can use the 4 Ps or the quick screen or CRAFT. We're all trying to get to SBIRT. We're trying to get to screening, brief intervention, referral to treatment. All difficult, right? Screening is difficult because patients have, barriers to divulging. Brief intervention is tough unless you do this a lot. And referral for treatment can be really hard depending on where you live, or you just don't know where to access it, or they have a 10-month waiting list, or I tell people all the time, I could never go to a methadone clinic if I had an opioid disorder. I just can't wake up at 5:30 in the morning and have to get to a place between 5:30 and 7:30, and then they close. I do not know what methadone clinics do between 7:30 p.m. and 5 p.m. I have no idea. Every city I've ever lived in, they're just closed. It's a barrier, and that's why having medication-assisted treatment like Suboxone and Subutex is a game changer, because now we can help people access at least their medication part of their recovery. That's only a small part of their recovery. So screening is a big part of this, but it's not the only part of this project. But we have to talk about how we learn about women and their substance use disorder. And sometimes they'll divulge, but sometimes we have to be active, and we have to set up safe spaces. I think we set up safe spaces so people can talk about anything that's going on, as well as their substance use disorder. We're in a way better place. So screening can be based on location. In a perfect world, and I'm dreaming, if we could do this all in the outpatient setting, so we could actually talk about recovery and delivery planning, and how do we talk to the newborn provider and what to expect, so it's not a surprise when they hit labor and delivery. That would be great. Let's talk about communication. What are your fears? I can do that over a course of 6 months of prenatal care, rather than that really intense time of labor and delivery and postpartum, when we're trying to get you out of the hospital in 48 hours. And if you ever mapped out the postpartum floor, we did that for a QI project back in Cincinnati. The number of people that touch a pregnant woman in a postpartum unit, just think about it. You have the PEDS provider, you have the OB provider, you have the birth certificate person, you could have WIC, you could have a ton of people. We overload women, and now try to figure out how we make it through your recovery, which is a really hard thing. Recovery is a lifelong pursuit for a lot of people with substance use disorder. It's really hard. That would be the perfect time. And I'm also a big harm reduction person. I spend a lot of my time talking to my own nurses, like, okay, you're giving us another opioid. Why are you doing this? How's this helping? And for those that work in this, think about what a person or a pregnant woman has to do to get her opioids if she's not in a program. And you get to very dark places you don't want to talk about, but it's real. So harm reduction is a thing. You can't do harm reduction unless you know the harm is occurring, and you can give them opportunities and tools and things to reduce that harm. So harm reduction is a big part of this. You can screen at the time of delivery, and that's what a lot of people do, in the other states that have done projects in this, but it's kind of checking the box to some degree, because it's kind of late. It's just too much going on. Like, it's not still an opportunity, but it's not the ideal opportunity. It's just, anyone that's working in a labor and delivery unit, I know how the questions asked. I work on labor and delivery units. You don't use drugs, do you? Great, check. Like, okay, that is not how you're going to find if a woman has a substance use disorder, right? It has to be, preferably oral, preferably validated, preferably in a space where you can talk about that one, like when your mom's there and your sister's there and your 5-year-old's also there. That's not when you're going to say, oh, by the way, I'm struggling, and I'm using my friend's Subutex. But there's still value in doing it, because we can stabilize the mom acutely. We can notify the pediatric providers. We can develop a postpartum plan. We do have different resources in the hospital. We have social workers. Like, that's great. I don't have a social worker wandering around my clinic. I wish I did. But I have good resources, and I have a person who's incredibly connected to the community. So there are different advantages and disadvantages of doing it, but we have to figure out a way to learn about the substance use disorder so we can help both the mom and the baby. That's really the big part of it, and it's really, really difficult. It sounds super simple. I can tell you the North Carolina experience it was not. Hopefully we'll do better in the Commonwealth. So, and it also just doesn't stop at the time of delivery. So this is data that's national data looking at the overdose rates during pregnancy and postpartum. It happens a lot postpartum, right? I'm looking over Dr. Rouse over here, and I now get to sit on NMRT, and I did also got to sit on the Maternal Mortality Review Committee in North Carolina. I can't tell you how many substance use deaths we had postpartum. And people who are incarcerated stayed, they were in jail for 6 months, and literally the day they get out of jail, they overdose. What did we do to them? We get them tools, that we give them the ability to deal with their substance use disorders when they hit a really stressful situation. Hey, you're out of jail. Are we ready? And the answer is no. And a lot of times people lose their Medicaid, not in Virginia, fortunately, but we still have resources. So we have to screen, we have to be available all the time, because the data, you follow the data. We learned that this morning. The data will show you postpartum is a really big time, as well as antepartum. And then the other question is, why bother? And this is my friend Melinda Rand, that she pretty much taught me everything I know about substance use disorder, who's a nurse practitioner who runs Project Care in Asheville. This is her slide that I stole because she said I could, but she's awesome. We spend a lot of time in OB screening for things that have a very low prevalence. We spend a lot of time talking about cystic fibrosis screening, really important. I'm not saying cystic fibrosis screening is bad. That only affects less than 1% of pregnant patients. We talk about preeclampsia, and people would argue that our whole obstetric prenatal care system is to look for preeclampsia. We take everyone's blood pressure. People used to dip urine every time. We stopped doing that a long time ago. It doesn't help, by the way, in a low risk patient population. We look at chlamydia. No one says you shouldn't screen for chlamydia. It's only about a 10% prevalence. You look at substance use, it's a 15% prevalence. Why should we be screening for it, and screening for it really well? Because it is a problem. Eliza said that really well. This is the impact. Can we do a better job in screening? And that might be where you want to go with this project. Everyone's going to go somewhere different. Screening is an important one, but doesn't have to be the only part. That's why there are lots of pillars. So you got to know that the mom's exposed, because if they have NAS, we want to take care of them, and we have a better thing than Finnegan scores, at least I think.
Yes. Okay. Thank you. So I did want to spend the last little bit talking about eSleep Console, because this is my love. And I think this is where a lot of people are going to be making big changes in the way that they're treating the newborns in the hospital. And there's a lot more to say about this than what's on the slide. So this is just a brief overview of what it looks like. So eSleep Console, it was a program that was developed at Yale a few years ago. And it is a very beautiful, simple scoring system. Can the baby eat at least an ounce at a time? Can they sleep for an hour uninterrupted? And are they consolable within 10 minutes? And it's a simple yes or no answer. And if the answer is all yeses, even if the baby is jittery or sneezing or having diarrhea, you don't start medical management. You use non-pharmacologic interventions, and then you can continue to watch the baby. At our hospital, we watch the babies for 4 to 5 days, because we think that's when the majority of withdrawal symptoms are going to start. Occasionally, someone goes home and they have withdrawal and they have to come back into the hospital for monitoring. But it is a 4 to 5 day observation period. What is so beautiful about this, aside from the simplicity, is it shifts the focus from medication treatment of the baby to, again, those non-pharmacologic interventions. How can you soothe the baby? What are the things that you should be, what tools can we teach you as far as soothing and swaddling and feeding that you can use once you go home? It's not, you did this to your baby and now we have to fix it with medication. It's, let us help you learn how to care for this child. So I love the family-centered part of it. So what they found at Yale is that they were significantly able to decrease the number of babies who actually started on any medication, and their length of stay went from 16 days to 5.9 days, which is really, really significant. I mean, again, treat babies like babies and moms like moms. So again, the three components is the infant feeding well. If they're breastfeeding, are they breastfeeding 8 to 12 times a day with effective latch and milk transfer? Are they feeding more than an ounce per feed? And it's really important to get speech and nutrition involved with these families early. We know that withdrawing infants can have issues with breastfeeding. It can affect their oral or motor function. So if you have speech involved, get speech involved early, really help with that. And then the sleeping and the consoling. We have a whole pathway that I'll go through at the end, but this is just what part of it looks like. If you're getting no's on any of them, then you go back and you look at all the non-pharmacologic interventions. Is there anything that you can optimize? And then if you're not improving, you start medication. So I cannot emphasize this enough. The non-pharmacologic care is the first line for all these babies, even if they would score a 10 on Finnegan. If they're eating, sleeping, and consoling, just continue to do the non-pharmacologic care. Again, it's family-centered. Part of what we really need to work on is decreasing stimuli. So we get these babies, if there are no other medical issues, these babies should be admitted to the general pediatric floor, not to the NICU. If you think about the NICU is like the most stimulating place and the least recovery focused place in the hospital. So get them onto the general pediatric floor. It also gives hopefully mom an opportunity to room in and be at the bedside as much as possible. Feed on demand, do the scoring on the infant's schedule. So if it's been 3 hours since the baby last ate, that's probably not the time to do your scoring because they're going to be fussy and they may be frantic. So try to do it on the baby's schedule. And think about hugs before drugs, empowering families, and rethinking and reconsidering what can we switch in the environment before we start medications. So often, the advice I got when I had a brand new baby was expose them to a lot of noise, vacuum while they're napping so they get used to it. These are not the babies that you want to send home with that advice. Like these are the ones who really need the white noise machines and the dark environments and the televisions off and the cell phones silenced. Cluster the care. So if the baby is sleeping, again, that's not the time to come in and do vitals or check their diaper. The supportive care that we're already doing in the hospital, but this is a great opportunity to teach the families and really get them involved. Skin to skin, the 5 S's. So shushing, swinging, swaying, sucking. So these are babies that we want to suck on pacifiers. And then holding them, teaching the families the different ways to hold them. And then good swaddling. If they're difficult to calm, can you do the vertical rocking? Can you show families how to do that gentle but firm clapping? And again, avoid the NICU. We understand that moms cannot always be at the bedside. They have a lot of conflicting things in their schedules. If they're in medication-assisted treatment, they're not going to be able to skip those appointments. So understanding that if mom is not at the bedside, it's not because she doesn't care or she doesn't want to be involved with her child. She may have transportation issues. She may have other children at home. She may have appointments that she absolutely needs to be at. So involving student nurses, involving volunteer cuddlers also to be at the bedside and realizing that may need to happen and not penalizing the families if they can't be there all the time. The nutrition aspect is really important. Feed on demand. These are not babies that should be kept on strict 3-hour schedules. Really feed on cue. Breastfeed if there's no contraindications. So obviously if mom has HIV or has hepatitis C with cracked nipples, or the drug screen was positive for multiple medications that she was not prescribed for, that would preclude breastfeeding. Otherwise, we should be including breastfeeding, even if they're on medication-assisted treatment. We think that the transfer of medication is fairly low. It may actually help with some of the withdrawal symptoms. So medication-assisted treatment should not be contraindication to breastfeeding. We do include marijuana in medications, so we don't encourage breastfeeding. And I know that can be controversial, and there's a lot more to come about that. And as I said, lactation support and speech involvement is going to be really, really important with these children. Formula feeding should not be the default choice, but if you are going to do it, something like Gentilese or a low lactose formula, these babies may tolerate that better. Weight loss, even with formula feeding, can be a huge problem. They may be frantic, they may have disordered feeding, not be getting in as much as they need. Plus, they're going to be hypermetabolic from their withdrawal symptoms. So increase their kcals really quickly. Generally, we try to see what we can do with 20 kcal formula and breastfeeding. But if they're showing weight loss, bump up to 24 kcals right away. We really try to nip that in the bud. If they really have a lot of oromotor dysfunction or there are other medical issues, go ahead and be aggressive, put down the NG tube and get those calories into them. That may also help with the withdrawal symptoms. So when do we think about medications? It's if we're getting consistent no's and we have maxed out our NPIs. So we're actually moving away from methadone. So the Eat, Sleep, Console method uses morphine instead of methadone. Morphine has a very short half-life. You can use it as a PRN medication. And some babies just need 1 or 2 doses, and then they get through that hard period and they're fine. Obviously, this is not a medication that we send kids home on. So it's also nice if they're on methadone, it's often a very long wean period. We used to send families home when they got to the very end. So hopefully send families home with no medications. You start with 0.05 milligrams per kilogram per dose. You can repeat it as needed every 3 hours. It is a team decision. So when we have a baby that's getting repeated no's, we will get together with the bedside nurse, with the physicians, with the family, and make that decision together. And then you can bump it up by 0.01 milligrams per kilogram per dose every 12 hours until you get good control so that the baby is getting yes on those 3 parameters. Your maximum dose would be 0.3 milligrams per kilogram per dose with a max daily dose of 1.2 milligrams per kilogram per day. This is a lot of nitty gritty. It'll all just, you don't need to remember all this now. And so again, you would increase it until they're again getting yes. They can sleep, they can eat, they can console. Clonidine would be your second line medication here. If you have babies who you've maxed out on morphine and they're still very symptomatic. It also, if you have babies who've been exposed to like benzodiazepines or other medications, in utero clonidine may be a better medication for them. And this is a medicine that we would send babies home on. So once you maximize your medication and get the baby settled, the goal then is to start weaning as quickly as possible. So get them over their hump and start coming down. So this is the protocol. It's very busy, but it has how we're monitoring them, the other interventions that we're using, when you would start medications, what the doses are, what you would use for secondary medications. And this is what we've been using for the past couple of years. And it has really been a culture shift. The first culture shift is getting these babies out of the NICU and onto the floor, or putting them in the newborn nursery initially, and then transferring them to the floor once the moms are discharged. It's been a big culture shift to check our biases. It is, and remember, nobody does drugs during pregnancy because their lives are fantastic. And these moms know that it's not great. They know that it's not good for their babies. They may have had other children who had neonatal abstinence syndrome, and they know what this hospitalization is going to look like, and they already feel bad about it. Our job is not to make them feel worse. Our job is to support them and their babies as they're going through this process. So using the non-judgmental language, being very careful about who's in the room when we're talking. It's a source of shame. Moms don't often share with other people that this was going on for them during pregnancy. So making sure that we're having conversations with just mom in the room or people that she's identified as support who knows what's going on with her. As we're giving, our job is to help them and to give families the tools that they need to go home and be successful. Involving social work. I like to phrase it, and if we're referring to CPS, that we're not doing this because we think you can't take care of your baby, but it's like an extension of the social work services that we have in the hospital. And they may have organizations in the community that I don't know about, and they can help you get hooked up. Again, emphasizing it's we want you and your baby to be safe. We want you to be successful. There are studies that having babies can be a significant source of strength and resiliency and motivation for moms to continue with their treatment and to continue with their sobriety. So they're going through a hard patch, but this really can have a good ending. Sometimes it doesn't, but it can, and a lot of times it does. So I think shifting our framework and how we think about this is really useful and can hopefully help these families. So that's kind of the big, what questions do y'all have? And how do I see if there's questions coming in?
How are you, first of all, one, do you recommend that? And when you have hospitals who say, we want to do universal drug screening, how do you respond to them?
Yeah, so that's been posed in so many different places, and I know there are protocols all throughout the country. They're different. So yeah, universal. If you truly do universal drug screening, it's probably more equitable than what we do now. Right now, we just sort of screen who we think is at risk, and it's probably full of bias. So if you do everyone, it's equitable. But as far as getting women into recovery, it kills the trust. I mean, you can't enter most programs until you as the patient actually make that first step. And if someone's not ready to talk about it and you're like, here's your positive urine, and what does it mean, right? If it's THC positive, when did they use THC? Could have been 5-6 days ago. We have a lot of things. There's so many things these are screening tests. So labetalol shows a positive amphetamine test. We put people on labetalol all the time. So it doesn't set up a really good trust thing. So I'm not a big fan of that. I'd much rather say, I want to partner with you. I want to learn. I want to be respectful. I want to meet you where you want to meet me. And during a urine drug screen, at the time of admission, that's sort of a required admission, right? Because you're having your baby, unless you're choosing to do a home birth or deliver in a birth center. I'm not a really big fan of it. Yes. Does it make the medical care better? Yes. Does it make the care for the patient better? I don't think so. So I'm not a huge advocate of it. But if you're going to drug screen, don't do it based on like IUGR or missed appointments. That's what a lot of people do. That'd be the worst of the three. But I see the desire. We were cord toxing people. There's getting cord toxins in every newborn, which is retrospective. But we realized it didn't really help us, because then it's like, okay, we have this result. Well, what do you do with it? And the patient's not willing to start, working towards recovery. And I'm thinking obviously very from a maternal standpoint, not surprising of what I do. I don't know what you think about from the newborn side.
I guess it would be nice to know, but also you have to look at cost effective. Like in this era, is that really the best use of our resources to be screening every mom? And is it going to be catching enough where it would make a significant impact? This question we need to ask as well.
Hello. Hey, I'm Mary from BHHA Foundation. So just a quick plug, if you are interested in accessing the maternal health dashboard, hit me up. If you are with the hospital, I am happy to get you that access that Shannon and Dr. Holland talked about. I do have a question about the the project and thinking about words that you were saying that were ringing bells for me, like community-based, outside the hospital, trust building, screening, connection to resources. Have you seen models or projects that hospitals have implemented that utilize either hospital and healthcare-based or community-based peer support specialists to execute on any of this work, whether it's education in a methadone clinic or working, right, getting a referral from a clinician in an outpatient clinic? We've done a lot of program growth in community health workers and peer support specialists and folks who are not clinical necessarily, but getting out in the community, building trust, screening for various health-related social needs, connecting to community-based resources and mental health resources. So I'm wondering if you've seen in other states that element being incorporated, so taking it out of just the purely clinical environment.
So yes, I mean, I have. I mean, I know in a lot of sort of comprehensive perinatal substance use programs, they have peer support specialists that are both there to help them journey, but also become kind of like community health workers. They go to appointments. They'll actually almost sort of like a doula. They will actually go into labor with them so they can be the advocate for, like, oh, you don't need pain medicines because you're on Subutex. Like, no, she's having cesarean section. She needs pain control. Like, this is crazy. And then there's definitely that continued benefit of how you interact with the general community, because it's like, oh, you understand this. And, you know, and I think it helps, it no doubt helps the woman who's pregnant. And it probably has lots of other advantages as well. So I've definitely seen programs like that work and be really, really effective. I think it also works on the other side. People that are community health workers who learn more about substance use disorder can be that really good advocate, because we were very unsuccessful in Western North Carolina with our hospitals talking about inpatient Subutex and how to start people who, you know, come in acute withdrawal, because once again, you're giving one opioid for another. This seems crazy. Why would you do this? And we actually had to teach charge nurses and nurse leadership the advantage of it. We had to go from the, you know, from the kind of the top down in the medical hierarchy. And we saw the same thing true at the community level. Like, a lot of people like, I don't get this. You know, we talked about needle exchanges, controversial stuff, and you need people in the community. Like, why do I want to do a needle exchange? It's like, well, they're, you know, honestly, they're going to probably use anyway. And the hepatitis is a real thing, because, you know, we spend most of our time postpartum now. I mean, I think at least 20% of our patients are Hep C. We do actually Hep C treatment in our clinic, so they don't have to go somewhere else. We try to do as much as we can, but that takes a lot of faith and trust. Like, why do I want this medicine? Like, you know, it's new. Well, it's 10 years old, it's new, but it works. So I think that trust is developed in a lot of different ways, but also it's just having people in the community, however they interact with the healthcare system, be part of it.
All right, thank you. Is it quick? Okay. Texted in. I know, that's why I cut you off. No, sorry. So thank you, everybody, for joining us. Thank you, Dr. Holland and Dr. Ollendorff. So we now have 10 minutes in between. Just as a reminder, if you're staying in here, it will be the Women's Veterans Program. If you are wanting to relocate to a different room, we have over there, we have Heartbeats, which is directly on the other side of this wall. And I'm assuming you don't want to hear this presentation again, but if you do, you're going to go diagonal is where that one will be. One more thing while I have everybody, and I was just notified of this for the lunch. They are going to break us out by rooms so that we don't have all 160 people trying to go through the line at the same time. So if you want to hear this one again, that will be the first room that gets released for lunch. Don't worry, there's lots of food, enough for everybody. But they will come to the room. So please stay in the rooms until they come and let you out and dismiss you. But there'll be plenty of time for lunch. So thank you, everybody. All right, we're going to get started in like, are you guys staying or leaving? Yeah, the veterans is in here. I thought you were looking for the other one. If you want to learn about the veterans program, you're in the right place. Eliminating bias is diagonal. So this is the heartbeats one right here. And then on the other side of that is eliminating bias in dyad care. And I'm going to say my own biases. This is where I would be. But I'm a veteran, so. Yep. Well, thank you. All right. So I am going to turn this over to Genevieve, and I have the pleasure to work with her and actually take advantage of this program. So this is, as I said, my own bias, near and dear to my heart. But this is definitely a collaboration we're really trying to expand with the VNPC. And I don't want to jump ahead because I'm sure Genevieve is going to cover it. But I want to introduce her, Genevieve Bennett, and she is a family nurse practitioner at the McGuire VA hospital. So without further ado, I will turn it over to Genevieve.
Hi, good morning, everyone. Thank you so much for having us at this wonderful presentation. I am going to go over all the women's health reproductive benefits that veterans can receive from the VA. Females are the largest growing veteran population in the country. So the VA has done a really good job of having comprehensive coverage. So we're going to go ahead and get started. So we're going to go over infertility benefits, IVF, maternity, and termination of pregnancy. So over the last several years, the need for infertility assisted reproductive technology has increased due to delays in childbearing, maternal medical conditions, and same-sex relationships. Circling back to those maternal medical conditions, those can be due from exposure to wherever they were stationed at, downrange, and any types of those types of things is what we usually deal with. We talk about the exposures to toxins, prescriptions for psychiatric medications due to specific treatments that veterans may be receiving for mental health, and then higher reports of sexual trauma, which can make it difficult to conceive. And studies have shown that female veterans do have a higher infertility rate for these particular reasons. As you can see, 15.8% of females who have been either in Afghanistan or Iraq are reporting infertility. All right. And then again, the VA, we're here for our veterans, so we want them to know they don't have to go through this alone. VHA Directive 1332 has established policy and procedures for the evaluation and treatment of infertility. The VA will provide evaluation, management, and treatment of infertility in accordance and accepted with standards of medical practice. The VA does mandate that all veterans eligible for treatment within the VA are entitled to evaluation and treatment. What the process is the veteran will need an initial evaluation in women's health, and this is to ensure all their routine screenings are up to date because reproductive endocrinology will not see them if their pap smear is overdue, if they are of age, if their mammogram is needed, things like that. An infertility consult will then be placed and a full chart review will be conducted. After these chart reviews are completed, they will either have a virtual appointment with gynecology nurse practitioner, or the consult will go ahead and be forwarded to the Office of Community Care. Once it's received by the Office of Community Care, they will then appoint it to the reproductive endocrinologists that are in our network. Once they receive that reproductive endocrinology consult, that consult itself will cover all infertility assessments and counseling, lab testing to include screenings, imaging, for example, if they need any ultrasounds or anything like that, hormone therapies, surgical correction for like if they've had their tubes tied and they want to have a reversal, or if a male veteran has had a vasectomy, it will cover that as well. It covers fertility medication and up to 6 rounds of intrauterine insemination. It does cover oocyte cryopreservation and sperm cryopreservation and sperm retrieval techniques to include washing and for IUI. What this does not cover is in vitro fertilization, donor eggs and sperm, surrogacy, or experimental procedures. If it is determined that a couple needs to have IVF for whatever the case may be, that reproductive endocrinology practice will need to submit a request for service for IVF in particular. This is a sticking point. This is laws made by Congress. We have no control over these things. And in order for IVF to be covered, this is the directive that discusses IVF. The patient must be married. They must be able to provide their own egg and sperm and uterus. They must have a service-connected disability causing the infertility. For example, if they have a history of polycystic ovarian syndrome and that is listed as a service-connected disability, so that means when they had their physical, when they were separating from whatever branch of service that they were in, that is listed. But their cause for infertility is they have endometriosis. If the endometriosis is not listed as a service-connected disability, IVF will not be covered for this particular veteran. Now, if they have endometriosis and that is listed as a service-connected disability and they are married and the male spouse can provide sperm, the female spouse can provide her own egg and uterus, then it is put through a committee where it will either be approved or denied. Now, at any point in time during this process, the veteran has the ability to appeal. When we start the infertility process with veterans and their spouses or whatever, the couples, whatever the case may be, you know, they are told this on the front end, so it should be no surprise on the back end if they need IVF of what is and what is not covered. There are several community resources out there that can help couples with the cost of IVF that the VA, you know, if they are not approved by the VA. Okay, now let's go on to maternity coverage. This is actually what I do. I coordinate all the maternity care for the Richmond catchment area for the VA. The maternity care is fairly comprehensive. It has been shown that it is imperative that veterans receive good quality maternity care, and this has become an Office of Women's Health national priority. Many of our women veterans are at higher risk for high-risk pregnancies for whatever the case may be, if it's mental health concerns, if it's exposure concerns. You know, they have a multitude of medical conditions outside of just being a veteran, and, you know, they're treated for many different things. The VHA Directive 1330.03 is the maternity coverage. It starts once the veteran establishes that they are pregnant. Prior to COVID, they would have to prove that they were pregnant either by lab work, an ultrasound, or whatever the case may be. Since COVID, that is no longer required. Once they notify me that they're pregnant, I will then put in the maternity authorization. So the details of the maternity authorization, it does cover all routine prenatal care, labor, delivery, and newborn care. It includes specialty and subspecialty if needed. For example, if fetal cardiology needs to be, if they need to follow fetal cardiology, that's included. If they need specific screening labs that are like genetic screening labs, all that is included. Pathology is included. It does include, it's very, very comprehensive, and because the VA can't possibly know what patients will need, so they want to ensure they're getting everything that they need. It includes all recommended screenings, prenatal education, anesthesia for labor and delivery services, postpartum contraception to include elective sterilization if it's done when they're in the hospital during labor and delivery. It includes an IUD or any other reversible contraception like a Nexplanon, the pill, Depo, whatever they want. It also includes any inpatient admissions if they are having issues with preterm labor, if they're having issues with kidney stones, or if they are having cardiac concerns that we've had, it all covers everything. And it does cover the baby for the first 7 days of life. This can be a sticking point sometimes for some people. Every time I talk to them, I let them know you've got to have other health insurance after the first 7 days of life. I encourage them to look at WIC and Medicaid. We do talk about, especially if they have medical conditions that the baby will require long-term expensive treatment, the importance of trying to qualify for Medicaid. It also covers circumcision if it is done in the hospital, immunizations as indicated, and follow-up visits for the mom for her postpartum visit up to 8 weeks. Okay, and then the newest thing, because initially the VA did not cover termination of pregnancy. However, with the overturn of Roe v. Wade, it was needed to provide abortion care for veterans in certain circumstances. The details of everything is still being worked out, but this is something that is important because this is sometimes needed. This is covered under Interim Final Rule AR 57. It now provides the authority to cover abortions in cases of rape, incest, and where the maternal health is at risk. The VA does not require burden of proof in case of rape or incest, and we are doing this for the safety of our female veterans. This does cover the initial evaluation, treatment, and follow-up visits as indicated on the consult order, and includes counseling regarding abortions, lab and pathology, imaging, anesthesia, pre-op medical care. It includes the procedures for abortion to include medication, induction of abortion, a DNC or dilatation and curettage, and or a DNE, dilatation and evacuation. It includes postpartum contraception and inpatient admission or observation for surgery or complications, and counseling. Our goal is to make sure that our veterans are taken care of in anything that they may need when it comes to their maternal health. That is it for my presentation. Does anybody have any questions?
Thanks, Genevieve. We have a question.
Okay.
Are you talking about leave for the benefits afterwards? So the question, Genevieve, is she heard you say 8 weeks for maternity leave, but some veterans take 12 weeks.
So it's the maternity consult covers the veteran for 8 weeks for their maternity care. It does not cover leave. So it's not like a payout program, like if you're at work and you're using your leave benefit at work. So the maternity consult will cover them through their 8 weeks of postpartum care. So once it gets them through that postpartum visit, the maternity consult is no longer valid. There are some instances where patients do need to continue care with their OBGYN past that 8-week mark. And then what I do is I then place a gynecology consult to cover them for what they're needing to be followed up for. But it's not like an FMLA program or anything like that.
Right. And Genevieve and I are working together on the 4th trimester, or the project formerly known as. So we are working to try and get some changes in place. So more to come with that. But this is an active partnership between the VNPC and the VA. There's another question, Genevieve. Is it a requirement to drug screen during prenatal visits? And is it a patient's right to know if they are screening, or can they do that without letting them know?
So the VA, if they're screening for prenatal care, the VA is not equipped to deal with any obstetric related care. So if they're being drug screened at the VA, it could be because they have a a pain contract or something in place that requires that. That would be up to the OB that they're seeing regarding the drug screening.
And just to elaborate, and my daughter was delivered through this program. So what it was is it was placed through the VA, but then all of my OB care was on the community side.
Yep.
Or on the civilian side. However, you're doing that. But if there was, I had endocrinology program care. So I would have that at the VA, and then there was that medical home model. So all of my records would go back and forth between the community and the VA. And then I actually did deliver at St. Francis under the veteran program. So there's no OB care at any of the VA centers. It's these consults. So everything gets done in the community. And this is why it's important for us to have this conversation, because many of you, if not currently, with the uptick of Virginia becoming the third largest state by 2030 for female veteran populations, this eventually you're going to experience this as far as that community care. So that's why we thought this was very important. And so this is where those connections need to be. So we have these bi-directional discussions on what is available at the VA and then how it is being utilized from the quality improvement perspective.
And I do know, like, with the veterans that I work with, and I have established relationships with their OBs. And if they present to the OB in crisis, they will call me, or vice versa. And there are some instances where, like you said, like if they're pregnant, but they have an endocrine thing that is a thyroid, they can get treatment inside the VA. But for the actual obstetric care, that is all done in the community. Cardiology will follow our patients. Endocrine will follow thyroid, but not diabetes. So it just depends on what they're comfortable with and what they're not comfortable with. But it's a great program, and it's great coverage for these patients because they deserve it and they've earned it.
We have one more question. Is this coverage only for VA, or can you choose where you go for care?
So this coverage, it essentially works like your insurance would work. So we are in network with OB providers. So if you want to see a certified lay midwife, that is not covered by the VA. They don't cover lay midwives, doulas, or home deliveries. So and I do have patients who still want me to follow them, and I will follow them, but they are paying out of pocket for their delivery. But if they want to see an OB that is a network and want to use their maternity consult, it will be covered. Sometimes they want to see an OB that is not a network, so they can either use their own private insurance or pay out of pocket. So they definitely have options and can pick and choose what they want to do.
And then an elaboration on that one. What about mental health during pregnancy and after?
So we actually have a great team set up for our mental health. I work very closely with 2 psychologists inside the Richmond VA, and they kind of work and branch out where they need to go. And they will get people plugged in. They will see them for counseling. They are creating pregnant and postpartum groups as a support group for our veterans during the pregnancy and postpartum period as needed. Again, sometimes if they're seeing an OB on the outside, psychiatry will manage their psychiatric medications while they're pregnant, because it can be incredibly difficult to get into an psychiatric OB facility. So they are managing their psychiatric medications, and then they're going to therapy and group therapy and all kinds of good resources. Social work is involved. So they do that's definitely from when I started at the VA to now, it's a night and day difference with how our mental health is doing with our pregnant veterans, and it's great to see.
So it's almost like a supplemental insurance where the VA would pay the OB provider?
Yes, so the VA will pay the OB provider, but the VA should always be primary. So sometimes people will have like So like my husband's active duty, so I have TRICARE, but I'm not a veteran. If I was and I wanted to use this program, I would only give them my VA information and they should only get the VA authorization. I would not give them my TRICARE because, you know, sometimes they want to build a private insurance first and then the VA, and the VA most of the time will not approve it.
Any other questions? All right, excellent. Thank you very much,
Awesome.
Genevieve, for being here.
Thank you, guys.
Hello, everybody. I have prizes. All right, we have 3 bingo cards that are already turned in. You guys didn't know that we would be giving out prizes for the early adopters. So Laura Shiflett, what would you like? We have a blanket, VNPC Sherpa blanket. We have a charcuterie board. We have a belt bag, or we have a VNPC North Face shirt. Which one? Thank you. I'm not done yet. Emily Moore. What would you like? Thank you. And Mary Layburn. Which would you like? And we can do a different size. So there's sizes if you want to exchange them. I just grabbed larger. This is the polo and this is the, oops, sorry, I did not mean to do that, or that one. Yep, take this to the desk and they'll give you the size you need. All right, I still have prizes. Okay, so who drove the furthest? How far did you drive? Ooh, can anybody beat Bristol? Anybody else? Paula drove from Atlanta, so we have to give her the kudos, but all right, anybody Bristol going? What would you like? All right, here's another fun one. Who is the youngest in healthcare? So who has been practicing the least amount of time in this room? Since, for clarification, down front, since the from graduating from their degree program. So 2021 with their master's in nursing. Can anybody beat that? All right, come on up here. All right, so because we went with the youngest, I'm not asking age. Who has been practicing the longest? Oh, do you want to? Donald's already won everything, y'all, and he's already got everything, so he does not count. 1984. Anybody else? 1984, going once, going twice. Oh, yeah. Do you want a shirt or do you want one of the belt bags? All right, it is 1:20. So don't worry, there's more giveaways, y'all. I'm not driving this stuff back. All right, Kelly. Oh, Kelly's right in front of me. All right.
Okay, there they are. Okay. I'm going to start today with some brief background to make sure we're all on the same page. So risk-appropriate care, or perinatal regionalization, has been promoted since the 1970s, and it's a simple concept: make sure pregnant persons and neonates receive care at facilities that have the staff and equipment necessary to care for them based on their health risks. The guidelines for these levels of care are set by the American Academy of Pediatrics and the American College of Obstetricians and Gynecologists and Society for Maternal Fetal Medicine, and have been embraced by many states. Generally, the way risk-appropriate care should work is that health facilities are assessed and designated as level 1, 2, 3, or 4, with 1 is the lowest and 4 is the highest. Pregnant people should deliver at facilities with the appropriate level of care available. So, for example, a person who goes into labor at 30 weeks would deliver at a hospital prepared to take care of a very preterm infant and potentially maternal complications. On the other hand, a person with a full-term singleton vertex pregnancy expected to have an uncomplicated birth could deliver at a lower level facility closer to home. Also, at the systems level, the level 3 and 4 hospitals work to provide support to level 1 and 2 health facilities when needed. The AAP published guidelines for levels of neonatal care in 2012 and reaffirmed these just recently. I'm not going to read through the table, but it summarizes the general staffing and equipment that AAP recommends each level facility have. I've also included a link to the full document at the bottom. ACOG SMFM published their latest guidelines for levels of maternal care in 2019 and reaffirmed these in 2021. Again, I'm not going to read through this, but the table summarizes the capabilities that ACOG SMFM recommends each level facility have, and you can click on the link at the bottom if you want to read the full document. The definitions, criteria, compliance mechanisms, and regulatory sources for risk-appropriate care vary widely by state. In 2019, 31 states had policies for levels of neonatal care. Of these, 22 required ongoing monitoring and 10 required site visits. In 2018, 17 states had policies for levels of maternal care. There are several other challenges to the risk-appropriate care system worth noting. These include reimbursement policies, implementation of the guidance from AAP and ACOG SMFM, and geographic context. So how does Locate fit into all of this? Locate contains questions that address guidelines by AAP and ACOG SMFM and produces standardized assessments to give health facilities and states information about the level of care the facility provides. It also facilitates stakeholder conversations and increases stakeholder understanding of the landscape of perinatal care available. The tool was designed to minimize burden on respondents, focusing on the key aspects that differentiate neonatal and maternal levels of care based on those published guidelines. It's important to realize that while Locate is based on AAP and ACOG SMFM guidelines, it is not a comprehensive assessment of all neonatal and maternal criteria. Again, this helps reduce the burden for respondents. Locate was also not designed to be a tool for healthcare regulation or formal designation of levels of care. This is just a quick overview of Locate history. Locate was first pilot tested in 2013 and has undergone continuous improvements since then. We're currently using version 9.2. At this point, 25 states, Puerto Rico, 1 perinatal region, and 1 large multi-state health system have implemented Locate, and a few more states are currently in the pre-implementation or implementation phases. Locate is completed using a web-based platform, either SurveyMonkey or REDCap, and my understanding is that Virginia plans to use REDCap. The assessment includes questions about equipment and staffing, subspecialists and their availability, self-designation of care, volume of procedures, drills and protocols for maternal emergencies, transports, and facility level statistics. As you can see in the blue brackets, some of the questions are used to specifically assess levels of care, whereas others are included mostly to help inform stakeholder conversations and identify QI opportunities. The locate process begins by building support for participation. This includes identifying champions, engaging stakeholders, and fostering relationships with facilities. When the state is ready to implement locate and collect data, the lead will provide facilities with the link to the locate assessment in red cap. The lead will also provide facilities with a PDF of the locate assessment. I find that it works best if facilities take a look at the PDF and gather all necessary information before actually using that web-based link. However, I would like to warn you that the locate tool in REDCap contains skip patterns. Therefore, the PDF looks much longer than the true assessment is. And this is especially the case for facilities that don't have a lot of subspecialists because a lot of the questions will not apply. So during the process, the lead can answer questions that arise and follow up with non-responders. Then when the data are complete, they will send me a de-identified data set. They'll keep a code set so that they know that Smith Hospital is Hospital 123, but CDC receives no information about the hospital name, location, or individuals who completed the assessment for the hospital. On my end, I will use the standardized scoring algorithm based on AAP and ACOG SMFM guidelines to assess the levels of neonatal and maternal care for each facility. I will then provide the results back to the lead, and keeping that key code set will allow the lead to be able to provide individual hospital feedback. Data in aggregated de-identified form can also be used and shared as desired within the state. One piece of information that's often of interest when states get their data back is comparing a facility's self-reported level of care to how they assess on locate. In a CDC analysis based on 765 facilities from 20 jurisdictions, the self-report and locate assessment did not agree in 33.1% of facilities for neonatal level of care. In those that did not agree, about 75% self-reported a higher level than their locate assessed level. These data were actually just published in the Journal of Perinatology last month, and I've provided a link at the bottom. In a similar analysis, the self-report and locate assessment did not agree in 46.6% of facilities for level of maternal care. As you can see, for both neonatal and maternal, the majority of facilities locate assessed as level 1 or 2. So locate results can be used for many things, including examining maternal and neonatal outcomes within and between levels of care, coordinating maternal and neonatal emergency preparedness plans and drills, and identifying priority areas and leveraging the Perinatal Quality Collaborative for implementation. We also have some state success stories on our webpage that give more detail about what other states have done, and there's a link to that down at the bottom of the slide. So with that, I'm happy to address any questions you may have at this time. Thank you so much for having me here today.
Thank you, Carla. That was very helpful. We're happy to take questions. I'll help facilitate. Any questions about the locate assessment? I heard a few people go, oh, I've heard about that. Is this coverage only for Virginia, or can you choose where you go for care? Tell me more about the question of coverage. We are going to be implementing this. That is, yep, you're right. That makes more sense.
Sorry, what was the question?
I'm sorry, that was actually a question for our previous speaker, so we can skip that one.
Thanks.
Yes. Is this question only for OB or does it include neonatal units as well in
Yeah,
Virginia?
The locate assessment is designed so that there's a couple modules. The first one is neonatal, and then there's a maternal module. And then there's a third module that just asks some general facility level statistics that apply to both.
Thank you. If you visit the Linktree app that's on the QR code that's on your tables, one of the options there to click through is actually a PDF copy of the survey, of the assessment, not survey. You got me, Shannon, of the questions so that you can take a look at them in advance. We recommend that you look through those. You'll need to collect some information from different areas of the hospital, but we think that this is a great opportunity to learn more about your facility, to do some self-learning and self-reflection. Yes. Carla, do you have any advice on getting buy-in from hospital leadership?
Yeah, I think the biggest thing is making sure it's clear what this is and what it isn't. I find that sometimes there's a lot of hesitancy because people think this is either similar to like a JCO visit, which it is not, which Kelly mentioned in her introductory remarks. Making sure it's clear that this is primarily for QI, not for any sort of regulatory or anything else that could be used maybe that could hurt the hospital in some way, shape, or form. Making sure it's really clear it's used for QI, that it's voluntary, that the data won't be shared with other facilities, that this will not be made publicly available. It's not even I, when I process the data, don't have access. So I think heading off some of those concerns I've seen in the past really helps bring in the buy-in from leadership across hospitals. And, if leadership has any specific questions that can be answered, they can be forwarded to me and I'm happy to provide more specific responses if that's helpful as well.
Our next question is, when is Virginia going to start this? And I can start to dive into that. We're going to be sending out the invitation to the assessment link this week. So all of you will now be on the VNPC email list. You'll be seeing that. We're also going to be distributing it through VHHA channels to our chief medical officers, chief nursing officers, and quality improvement teams. So we'll be following up with individual health systems to find out who's been identified as the leader for their hospital's assessment and remind you of some timelines. We're going to be having an office hours call in November where folks can call in and learn more from Carla, ask more specific questions once you get a chance to look at what the questions are on the assessment. And the deadline will be in December for the first round of submissions. If we're successful, we're looking at perhaps doing another round of this in 2023. But for the first time around, we'll be having that deadline in December. And Carla's a wizard. She will turn around the assessments fairly quickly, and we'll be able to get you your information early in the new year, if not before then. Next question, although no regulatory expectations, are you seeing any research related to maternal outcomes and balance of levels of care in states that are already involved?
That's a great question. So we are working with 5 states right now who are linking their locate data, their hospital level locate data, to their individual level hospital discharge files. And we're working on an analysis looking at associations between a set of risk conditions and a set of outcomes, and seeing whether hospital level of maternal care is an effect modifier. So whether we're seeing better outcomes among people with these risk conditions at higher levels of care. That is ongoing. It's something I've been working on very closely with these 5 states, and I hope to have more concrete information and results in the next several months. But so that is ongoing. And, if Virginia wants to participate in something similar after doing this, I'd be very, very glad to have that conversation.
Thanks, Carla. I think that's a nod from several heads in the room, so we'll be following it more. Any other questions? You will inevitably think of questions once you get a chance to read those. Read the assessment tool, so check it out on the Linktree. Be on the lookout later this week for email messaging with more information, and we look forward to partnering with you. Thank you so much.
man, you all are running like, we're on time. We're ahead of schedule again. Like I never get to say that for this. Okay, so I get texted reminders from everybody. So I'm asking this for maybe Sabrina, but if everybody can look at the yellow sheet over the next couple of breakouts, if you want to take it so that you can, or scan it and then hold it in your phone. So there's a lot of links there. What we're really trying to do is we've moved over to MailChimp for making sure you guys get information out. I promise we will not inundate your mailbox, but I'm constantly being asked, I didn't hear about this. I didn't know this was going on. And so this is our main way right now is to get information out is through the listserv. So there is a link on Linktree. Make sure that you please update your information if you want to be on our listserv. The other thing that we're starting new, again, is sometimes we're all busy, but we all have one thing that is always next to us, except I don't have mine, it's right down there, is our phone. And so we're going to start a reminder system with text. But in order to do that, we need your cell phone numbers. I promise we will only do it as reminders. And then you at any time can opt in or opt out. But if you could please sign up for that. So we can send reminders because I know we all get busy, but sometimes there's things we really want to go to. And then one more thing is please, I'm seeing some hashtags. I'm loving it. Hashtag VNPC 6th annual. If we can please keep those up. I'm going to put a little bee in everybody's bonnet. We have somebody here from HRSA for our region of 3. And they may or may not be looking at states and kind of learning so we can share and collaborate. So your picture, if it's shared, may or may not make it out there into the bigger realm of maternal and infant. So please participate with that. And other than that, we're going to have another break. Are you guys liking all these breaks? Okay, because remember this when you do your evaluation. Because this is from everybody's evaluations. So we are going to take another break and we are going to breakout sessions. I don't have an agenda. What time's the? So 1:50. So we have about 8 minutes. 8 minutes. So in here is going to be part 1 and part 2. We're asking if you start with part 1, you stay for part 2 in here for the setting the stage for the collective impact. Now, this is going to be ran by the Maternal Quality Care Alliance. So I know we keep talking about that. That was our community engagement private. We changed the name. And you guys, it's going to be awesome. But I don't want to take away from any of the other awesome presentations too. So I know there's several in here that want to know about the 4th trimester progress. And we have some very exciting updates from Carillion and Centera. So they are actually going to be in that room, diagonal. And then right on the other side of the wall here is our point of care ultrasounds. And they actually have ultrasounds and they're going to be doing some simulations. So if you guys are interested in that, that's where that will be. So everybody will stay, the topics will stay in the rooms this go around. And I get it. If you come to part 1 in here and it's not your jam or you want to move, you can move. Okay. You don't have to start and stop here. So, because the other ones are really awesome too. So, all right. Without saying that, so 45 minutes, then will be 10 minutes in between to move rooms because we haven't fed you enough. And I heard we only got 3 shrimp. We're going to have a break with more food, you all. So food will be out there really all afternoon. So nobody should leave here hungry. And that's it. All right. And don't forget to come back in here at 3:30 because I will be drawing for more prizes. So all of you that like to run out early, that's fine, but there will be no prizes because you have to be present to win. All right. All right, everybody, we're going to get started in about 30 seconds. So I know we like our comfort zones, but we're going to get out of our comfort zone in this meeting. So if you are sitting at a table by yourself, or if there's only 2 people, I need you to move to a table because we're going to be doing some table work. You guys didn't know that. You want to change sessions now? Too late. So if you, so this is where we network, which always comes up on evaluations. Liz, we're moving a few people around, getting them uncomfortable so you can have your, and Arthur and Jackie won't bite. Okay, maybe. Okay. Eliza, you want to move? Okay. All right, so I have the pleasure of introducing our next 3 speakers, well, 4 technically. So we have Stephanie Spencer is the chair for the Maternal Quality Care Alliance. Unfortunately, she was not able to join us today, but she has been checking in throughout the day and she misses us. She wishes she was here. But we do have the other members of the Maternal Quality Care Alliance committee with us. And so we have Jamia, we have Natika, I always say it wrong, and Sultana. I just saw her. All right. And then joining us virtually is Liz with the Tamarack Institute. So without further ado, I am turning it over to these lovely ladies and you guys will be in good hands.
I guess I'll start and then I'll hand it over to Natika to take us to the next, to set the context and to take us to the next level. So wanted to share with you that this is the first part of a 3-part series. Right now, we're going to be talking about the Maternal Quality Care Alliance and talking about it in the context of collective impact. And so you'll hear a little bit about the work of the Maternal Quality Care Alliance. Then I'll come in and share with you a little bit about collective impact. And then there's a great opportunity for conversation. Part 2 will also be today. It'll be at 2:40 today, and it's more workshopy than conversation, although we do have an activity for you, and it's really going to focus on building trust for impactful collaboration. And then part 3 is a webinar that will happen in January of 2023, January 17th, where we're going to go a little bit deeper on building trust and really thinking about how do you build trust with intentionality and how trust is such an important factor for collaborative work. So that is the 3 parts of this series. So part 1 and 2 today and part 3 in January. And then the other thing that I'll do really quickly is just bring forward the agenda for today. So you can see we've got a fairly packed time schedule for the 45 minutes that we have together. So now I'm going to turn it over to you, Natika, to ground us and set the intention.
Thank you, Liz. Good afternoon, everyone. How are you? Excellent. Thank you.
So I am the workforce development manager at Urban Baby Beginnings, but I'm also a clinical herbalist and a yoga therapist. So mindfulness comes into everything that I do. It informs a lot of the work that we perform in the community through Urban Baby Beginnings. And I would invite you all to participate in a centering exercise. We know that mindfulness has a really profound effect on all of our well-being. Folks in this room spend a lot of time caring for other people. I want to invite you to turn some of that awareness inward to how are you caring for yourself in this particular moment, not overall, just right now. So if I can invite you to become present in this space, and that begins with sitting squarely in your chair, ground your feet, put both feet down, lengthen your spine, roll your shoulders back and down, lengthen the crown of the head up high towards the clouds, and come into this moment as much as you can. And it's a slow process. We'll start by just sort of decompressing your breath. How is your respiration? In and out. We know that our breath happens involuntarily because our body has this will to keep us alive. But when we are intending more voluntary breath response, that's when we move into the space of thriving. And so if you can now let go of the air in your lungs, exhale through the nose and see if you can soften the muscles of the face. Breathe in through the nose, fill the belly, fill the ribs, fill the chest, and exhale again, letting that relaxation from the face travel down over the neck and the shoulders. Inhale, breathing in through the nose, filling up with a fresh supply of oxygen. And as you exhale, allow that relaxation of the muscles to travel down the abdomen, over the hips and the legs. Continue breathing in and out at your own pace, and notice where your mind is as you're breathing. Are you here in this space right now? Are you aware of the sensation of the air crossing through your nostrils? If your mind is distracted, it's okay, it happens. See if you can come back to this moment. Coming present, taking this time for yourself, it's a really beautiful cultivated skill. Focusing on the breath, the most simple of things that we can do for ourselves, really goes a long way. And that helps us also to set an intention for this space in this moment. What is your intention for attending this conference as a whole? But then also, what was your intention behind choosing this workshop? Take a moment and think about why you're here and how are you showing up. Let us begin with a shared understanding that the disparities in maternal health field have real and damaging effects, and that we're all here to make change in that way. Let us unify around that shared goal of eradicating the systemic issues which lead to harm for many people in our communities. Let this be a starting point for each of us to continue with an attentive listening ear, listening in the way that seeks to understand, and support that listening with a compassionate heart. What we digest and understand is the foundation that we'll build upon as a community of care providers. Continue to breathe as easily as you can, and when your mind gets distracted, just simply come back to the breath. Simply come back to your intention of why we're all here working together, letting down our barriers and the things that sort of keep us separate, knowing that we're all here for the community of the people that we serve. Hold that as your intention as we move into the work that we're going to do today and beyond. Keep breathing, but let your eyes flutter open. Keep your awareness here in this moment and see if you can stay present in the room, no matter what else is happening in the world. You are here for the people that you serve and the growth and the evolution that come from that. Thank you all.
Take a deep
Thank you so much, Natika. That was lovely and a really great opportunity for us to ground us in the work that we have together. Now I'm going to ask Sultana to describe the Maternal Quality Care Alliance journey so far. And Sultana, I just will let you know that I did put a slide in that looks at the draft plan on a page.
Oh, perfect.
Okay.
All right, everybody. Hi, my name is Sultana. I am the Deputy Director at Postpartum Support Virginia, and I'm also a licensed therapist in private practice at Crane Counseling Services. And I'm just going to tell you briefly like where we were at the first summit. We talked about health systems. We moved to the second summit. We talked about community-based care. Third summit, we talked about safer childbirth cities. The last summit, we talked a lot about how can we incorporate the community voice and perspective, especially as we talked about throughout today, disparities for perinatal individuals. And then today we're going to focus on listening, learning, changing, building trust within the community. At everyone's table, there is one draft of our plan on the page, and I'm just going to briefly kind of go over everything that you see on there. So the Maternity Quality Care Alliance, our plan starts with our approach, which we are a network of individuals and organizations seeking to improve maternal and child health care outcomes in Virginia. We're collaborating with individual systems to reduce poor birth and postpartum outcomes for mothers, birthing people, and their children through a collective impact and collective lens. Our vision is to align aligned coordinated care networks that optimize the care experience, health outcomes, and utilize of clinical and community-based services for every perinatal person that we serve. It also focuses on a person-centered approach. Our 4 type priorities are achieve health equality, prioritize community voice, because if we don't know what the problem is, then we can't work to fix the problem. Education and support, and then advocacy and co-design. And that's why we're here today. We're going to talk a little bit more of how can we, every individual in this room, contribute to the maternal quality care. The way we're going to make an impact is through communication, empower, engaging, contribute, and coordinate care amongst everyone.
Thanks, Sultana. So you can see in this design of the plan on a page, it's got these bars in front of it, and it's really intended to be a draft. And so a draft that is informed by all of you in the room. And that's why we're at the session today. And you're hearing a little bit more. This was put together by the folks that you see on the plan on a page, but also you see that final circle, which is you, which is really the opportunity for you all to contribute to building this together, because it really is intended to be a cross-state collaborative, co-designed approach, as Sultana said, and really excited to have you all engaged in the conversation. I'm going to do a couple of slides, talk about a couple of slides, and then we're going to have you respond to some questions that we have and give us some advice that you can contribute to the early thinking. And we'd love to also have you think about how you might want to be involved going forward, because to get to the vision, the approach, and the impact, it's not just 4 or 5 people that can achieve that. It's actually a collective approach across the state of Virginia, utilizing the capacity and engaging the capacity of lots of different organizations and people, and also including the perspectives of birthing people and how they access the system overall. So that's what I'm going to do during the next part of this. So I want to give you a little bit of the construct. So as Sultana told you, over the last 4 or 5 summits, you've been on a journey together, and you've been on a journey of exploration about, the state of maternal health in Virginia, but also listening to community voices. When we think about collective approaches at Tamarack, we think about 4 factors that we consider to be instrumental. The first is the readiness of the community to respond, and community readiness really does look at, communities that have leaders that come together, that are engaged in the work, that are willing to step up to the plate. And to some degree, the MQCA is that, right? There, in that community, there are at least 5 leaders that are stepping forward, and we're inviting more leaders to step forward. So community can be both place-based community, but can also be a community of practitioners who are willing to move forward with their work. So that's the first thing. The second thing is really trying to understand the context in which the community is operating, whether it's place-based or a community of practice. And so what are the things that are happening in Virginia that you want to be paying attention to ensure quality outcomes for birthing people and their children? So thinking about, what's happening at the state level, what's happening across the United States, what's happening in smaller, more discrete communities and neighborhoods across the state of Virginia, and then what might you be able to impact? So what's within the scope and the reach that you can impact? So community context is the second element. The third element is complexity. And we know that, advancing quality health outcomes is a complex issue because there are different ways that the programs and services are delivered across the state. There's lots of different organizations involved in the larger ecosystem of care. And you're also dealing with different population dynamics, those who have health insurance and full accessibility, those individuals who may have only partial accessibility, and those that might have many, many more barriers to accessing the right kinds of supports that they require because of health reasons, because of community reasons, because of transportation. So it's a very complex set of issues and circumstances. And so collective impact is best kind of suited to a more complex issue. And then you want to think about the approach, and MQCA has identified collective impact as the right approach, and we'll talk about that in a few minutes. It's also really important to kind of think about where this collaboration sits on a spectrum of collaboration. And about a month ago, we had this conversation within the individuals who are already part of the MQCA. And we said, okay, so where do we think the current work of MQCA fits on this collaboration spectrum? And some folks said, well, we're pretty good at communicating and we do cooperate, but only a little bit right now, but we would like to get to coordinating action and collaborating. And if you look at the spectrum, the couple of things that you want to think about is, to what degree where are we on the spectrum? And then depending on where we're sitting, how do we intentionally build trust amongst the partners? And what are the things that we're going to be doing? And in the collective impact framework, communication, continuous communication and building trust are pretty important components of a collective impact approach. But the collaboration spectrum is really helpful as a guiding tool to understand where a collaboration is right now and where it might want to get to in a year, 2 years, 3 years. Some collaborations only stay in one place and don't move. They agree. Everybody around the table agrees that that's the place we want to be. Others, as the MQCA team have already determined, they see the opportunity to be more intentional and to work more in a way that leads to better and more coordinated outcomes for birthing people and children across Virginia. So 2 really quick slides. I've mentioned collective impact a couple of times. It's a framework. So it's a framework for considering how to move population level change forward. So when we talk about better outcomes, that's a population level change. We're looking at birthing people and children, and we're trying to improve the outcomes for those 2 population groups. And we agree that we're going to be doing that by working collectively together. There are preconditions for collective impact, which include having the right champions around the table, understanding the issue more directly, looking at data and evidence that is related to the issue, and really understanding that, you know, there's an urgency behind it, that there are individuals across the state who have less effective outcomes, may die in the birth process, may have poor birthing outcomes for their children. So there's urgency around that because the data and the evidence tells us that, and that there are enough resources to help this work go forward. And resources are both human resources, but also financial resources. And so really considering, you know, what will it take to influence policy and systems change and get to those population level impacts. And then the core parts of the collective impact framework are that, you know, we have this common agenda. So Sultana took you through the plan on a page. The plan on a page is the expression of MQCA at this point, now to be informed by all of you in the room, but the expression of this common agenda. It also includes, in some of the conversations that we have, are some measures of what success will look like and what are some impactful measures, what does data tell us about this issue, mutually reinforcing activities as part of this framework really is about all of you in the room. It's about the work that you're doing in your own organizations and in your own practices, and really thinking about, okay, so what am I doing to improve outcomes for birthing people and children, and how can that align? How can that contribute to the shared and collective work of the MQCA and of other initiatives that I've learned about by attending the session today? Continuous communication, that's where trust comes in and transparency. And so part of what we're doing today is talking to you about what the MQCA is thinking about, but then also engaging you to inform us. So it's not just a few people sitting in a room, that it's actually many more people contributing. And this is only the first step of this process. And then backbone is providing resources to make sure the work moves forward. And that's, you know, Stephanie and Sultana and Mia and Natika and others that have already stepped up into the plate, Shannon and others that have already stepped up. So that's the framework. So now we're going to put you into your table conversations, and the members of MQCA that got introduced at the beginning of the session are going to facilitate the table conversations, but here are the questions that we would like you to consider in your conversation. So what questions do you have about the MQCA approach? What is your organization already doing that might contribute to improved health outcomes for birthing people and children in Virginia? And where might you like to contribute? So we're going to give you about 10 minutes for this conversation. And then I'm going to invite the table groups to share a couple of themes. Mia, Sultana, Natika, and others are going to facilitate the conversations going on at each of the tables. So I'm going to throw it over to you all to engage in conversation. And I'll let you know when your 10 minutes are up. one more minute for your conversations. Okay, everybody, thank you so much for engaging in the table conversations. Mia, I wonder if you might be able to facilitate in the larger group some of the ideas that came out of the table conversations and also some reflections. And so now we want to wrap up this session by having Natika come back and do a connection exercise. I don't know if that's happened or not. I couldn't hear anything, but I know the session wraps up in 3 minutes. So Natika, hopefully you can grab a microphone and do the wrap up exercise for this session.
Well, good afternoon, everyone. Hey, we're going to settle down at our tables. Some of the reflections I heard from the table. So thank you again, you all, for having great conversation and leaning into the questions. I know this was a lot to take in a short amount of time, but I think we got some good things happening with each one of you. So some of the things I learned, and I floated to a couple of tables, so I'm sorry for those I did not get to talk to specifically. But one thing I heard a lot about when we think about how we're going to move this work forward. Communication, 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 right? I heard that through all the table. Like, how do we link the conversations together? How do we link resources in such a way that it makes sense? And how do we stay connected, not only with the work that we're doing in our own individual organizations, but then how do we cascade that to partners, to bring a friend along, to keep that going? So communication was one thing that I heard a lot about from a lot of the tables. And just, as we think about it, as we leave this place, think about how we're talking about this work, what we're saying about this work, and then who are we saying it to? And that's how we get to that community level engagement with the birthing people, boots on the ground, and their families. Another thing I heard was the idea for more information. Some of you just kind of didn't even really know what MQCA was really all about. So what that tells me is we have to do more work with communicating and sharing what we're thinking about so that we can push it and cascade it to you all so we have a better feedback loop so we can understand what are the needs from clinicians as far as community-based partnerships. What does that really look like? How do you really do that? How do you really build trust? So that's something I heard. And then also really looking at the social determinants of health and how does that cascade to that community-based level? Because what we understand in the clinical terms, people's health, 80% of people's health is where they live, work, and play. The 20% happens like in the clinical facilities. And that's kind of where our space is for some of you, is in that clinical field, which is great. And then we patch folks up and then they go home where they've got poor water, poor housing, no transportation, no money for food, no childcare. And then they end up getting sick and coming back to see us, what, in 30 days? And we all know we don't get paid for those readmissions. And so there we go. So that was something that we also learned from the table. Any other reflections that I can put on my list to take back to our group? Any brave souls? Oh, yes, ma'am, in the back. Yes, ma'am. You want to come up? Come on up. Come on up. Okay. Could you do that? That'd be
Perspectives at our table. Oh, thank you. Now I'm going to have to do a whole stand-up act because I'm holding a mic. But we talked a lot about how there's a huge disconnection between hospitals and community services, and that sometimes, you know, there's an expectation that those who work in the hospital or the medical environment should know the services, but they don't. And how does that information get shared about community services? And it's wonderful when you learn from a family member or a caregiver that something is out there, but why is that how, you know, it's great that they have access to something that you don't know about. But we talked about that disconnection, and then also the role of social media and how that could really be something to leverage. And why can't we just share a link? You know, why are we not just, you know, sharing some kind of information that the families or the patient can step out with on their phone, as opposed to a printout or a handout that is probably not going to be read. It's going to get lost in 17 pages of a medical summary or a visit summary or a discharge summary. And then we also talked about there's sometimes just not the right people sitting at the table. And that it's really important to really make sure that the frontline workers who are actually the ones who are at that kind of knee-to-knee engagement is learning about things at the same time as their upper leadership. They need to be involved and in the know, but sometimes that doesn't come down to where the action actually takes place. And because of that, that creates way too many cracks for our population to fall through. And maybe, I mean, there's probably a number of reasons that there are gaps and things can fall through the cracks, but that we think that may be one of them. And I think that's it.
I'm hearing VPNC, TikTok. Just saying.
Y'all don't want me to dance.
Any other folks who want to do a report out? We've got the roving mic, which is exciting. Anyone want to share any more learnings to kind of help?
I'll use this. So there were a couple, I think, things that we wanted to highlight and champion that are going on. There's a hotline for maternal mental health that HRSA.gov offers that folks can call 24 hours a day to support. The number is 833-943-5746, 833-9-HELP-4-MOMS. So put that in your resource kit. That came out of this working collaboratively. So it's something that all of us can use, and they roll up to the 988 mental health number if additional resources are needed. So also another thing that we wanted to champion is that Medicaid offers doula services and support. If that wasn't aware, that's out here too. So those are some of the things that are floating around in our circle. Anyone else?
The essence of being timely. We need that number again on the microphone.
All right, the
Super
number
loud.
again, 833-943-5746, 833-9-HELP-4-MOMS.
I'm gonna turn it back over to Miss Natika. She's gonna wrap us up and bring us all in for a warm fuzzy. Okay.
Thank you, Jamia. Well, here comes the experiential aspect of our time together. And we actually need to stand and come together. You make a circle, which might be a little bit challenging. We might need to move a couple of tables out of the way so that
When I say make a circle, just imagine that you're in a room like you were in kindergarten. Remember, everyone in your room was your best friend. There were no divisions and no barriers because we just didn't know that. Roll yourself back to that time. Come into the space with a sense of creativity here and that kindergarten like adventure, and make a circle, shoulder to shoulder, shoulder to shoulder. We might just do it around the tables. So stand up, make a new friend, shoulder to shoulder. And if we need to move tables, we'll do that. All right. Oh, I love it. Yes. Are you gonna really need to get shoulder to shoulder? You're gonna have to be touching somebody, which might mean you step in and create a 300, not an oval, a real circle. While you all are figuring out how to create your circle. Yeah. If it's easier to create, no, I want one circle. One circle's better. Yeah. One circle. One circle, shoulder to shoulder. Okay. So shoulder to shoulder means that you're touching someone. Get closer. Hip to hip, shoulder to shoulder. It won't work if we're not in our circle. Okay. Good job. Okay. Excellent. All right. So now from this particular position, we're going to raise our arms, stretch them up, relax your shoulders and relax your face. Take a nice deep breath while you're here. Remember, you're amongst friends. Bring your arms down behind the back of the person next to you. So your arms are going to be right under their shoulder blades. Yep. Now you roll your shoulders up, back, and down so that your heart lifts up and shines forward. Does anybody remember the Care Bears? Yeah. You each have a special power. You are each individual in your own way, and let that Care Bear energy shine out from your heart. Your arms are right underneath the shoulder blades of the person right next to you. And it's important that we're here feeling the support of the person to your left and to your right. If you don't feel that that person has you, step a little bit closer so that you really feel that you're supported by your neighbors and the folks in this work with you. So again, tap into your breath. Remember that easeful in and that easeful out. We are sharing space with one another with all of our collective Care Bear energy beaming into the circle that's fueling each of us. Now, if you're going to send your Care Bear energy out, but also lift it up so that it transcends this particular space. Lift up through your heart, look up toward the ceiling. Imagine that you can see beyond the ceiling, up into the clouds, up into the potential of the effort that you're making into the world. Begin to lean back into the arms of the people supporting you in this work and keep breathing, right? This is why the circle is important. So you're holding. Keep breathing. On your next inhalation, lift up tall through the crown of your head and come back up to stand. Keep holding to the person to your left, person to your right. Look around the circle and see who's here with you. As we are sharing space, we're moving away from the me toward the them mindset. What affects our neighbors affects all of us. So here we are rolling up our sleeves to get into this work. If you think about the South African term Ubuntu, some of you all might be familiar. We do this together. The fundamental approach to life, kindness, humanity, compassion, unity. Let that be the theme of the work that we're doing here together. Moving away from my organization to our organization to serve the collective. We continue to build trust away from whatever happened in the past, moving forward into a new future together. Look again to your left. Look again to your right. We can continue to expand this circle to allow other people to join us in this work. It's a continuum. Let's keep going together. When you feel ready to let go of your neighbors, let your arms drop. But keep this togetherness. Thank you all so much. Take your break and we'll see you back for session number 2. Oh, good. Oh, thank you. I'm happy to.
All right. Hello, everybody. I did a double check. Is this just Liz running this, Sultana? Okay. All right. Hi, Liz. Sorry, we took a little bit longer break. Note to self. When there's food involved, I need to give you guys a little bit more than like 5 minutes. So, all right. Liz, you're going to have to help me. Is it just you right now?
We can have it just as me. Do I go until 3:30 so that you're back for your final keynote?
Yes, ma'am.
Okay. So we'll have to rock and roll through this section.
We can do it.
Yep. So, hi, everybody. Do you want me to get underway, Shannon?
Yes, ma'am, please.
Okay. Hi, everybody. Welcome to the second part of this, Building Trust for Impactful Collaboration. And this one, we're really just going to focus on what it takes to build trust and how to build trust. This is the first part of a 2-part series, which I already described. So we're going to be doing the second part in January around trust. And we're really at that point going to be looking at navigating turf and rebuilding trust once trust breaks down. And we, you know, from the first part of the session, the setting the stage for collective impact, trust and collaboration are interwoven concepts. And so we thought it would be good to spend, you know, about 30 minutes with you, kind of thinking about building trust. We did have some setting the stage, but we're just going to jump past those. You already met the members of the MQCA team. They're very excited about this work and the contributions. This is what we're going to be doing. We're probably not going to do the exercise because we don't have quite enough time, but I'll walk you through the exercise so that you can use it either in your work teams or in your family teams or wherever you'd like. So I always think about trust as the intentionality behind trust. And so it's really about how do we build our trust toolbox is really the idea behind this session. The goals for the workshop are to deepen our collective understanding and, as I mentioned, to build our trust skill set. And so this session really has you kind of moving out of your comfort zone. Most of us spend 80% of our time in our comfort zone, and this is really moving into your learning zone to really think about things that might be a little bit more risky, to have courage, to act in the face of fear, because sometimes when trust breaks down, we don't want to confront it, right? We just want to have collaborative spaces, be happy spaces. And so sometimes it makes us kind of think about, okay, so how do we confront sometimes some of that uneasiness that happens with building trust? Okay, the thing about trust is that trust really is part of our brain science. And so there is this science behind trust, and you can actually see how people feel about their experiences by how much they lean into the experience. That's the trust in the prefrontal cortex, or how much they lean back or might cover their, fold their arms. And that's kind of when they're sharing with you some signals that they may not fully trust the experience that they're involved in. And so trust is, we have a physical reaction to it, particularly when we're in a collaborative context. And we're also doing these things. And this is called the SCARF principle, right? So we're thinking, and this is not only true for me as an individual, but for everybody that is entering into the collaborative space. They're thinking about the status that they have relative to other people in the room. They're thinking about how certain they can have to predict the future. So are they able to predict the future? Will they be able to commit on behalf of the organization? They're thinking about the autonomy that they have, the sense of control they have about the event or about other events, the relatedness, the sense of safety and connection to each other. And for those of you that were in that last session, standing shoulder to shoulder was creating some of that connection. And then the fairness. Is there a perception that if I share my ideas, if I share my story, will you listen to me, and will there be a fair exchange? And so there is this kind of neuroscience that really informs thinking about trust. And I think it is for those of us that are convening collaborative groups or working in team environments, we have to pay attention to how people are leaning in. Are people engaging with what we're saying? Are they listening intently? Are they feeling safe in this environment? And so all of this goes into kind of the big ideas around trust. Stephen Covey talks about trust from the perspective of 5 waves of trust. And he wrote this book in 2012, The Speed of Trust. And he really thinks about it in a way that, it all starts with self-trust. Self-trust is this first wave, right? So do you trust yourself to fulfill the commitments that you're going to make to the others that you're going to engage? Whether it's commitments you're making to your other team members or your workmates, or commitments that you're making around a collaborative table. So self-trust is that kind of first wave of trust. Then it moves out to relational trust. And that's the trust that we normally think about, the extending of trust to others, others extending trust to us. That's all about relational trust. Then it moves out to the third wave, which is organizational trust. And organizational trust is really interesting because each of our organizations has a reputation. Right. And so do the folks that are coming to our organization looking for services from us or organization, do they trust it? Right. Now, Covey wrote this book for the private sector. So then he talks about market trust and societal trust. But these are still interesting concepts within the collaboration sector, because it's really, does the broader community believe that the MQCA and all of you will be able to achieve better health outcomes for birthing people and children? And so that really ties into market trust and societal trust. So Covey says these waves kind of spin out, but they start with self-trust. And then he goes on to say that there are 13 ways to build trust, right? This is that kind of starting at the very core. These are practices that we can build in to the work that we do to really build that kind of trust. And in his book, he wrote about, talking straight and demonstrating respect and showing loyalty, delivering on results, clarifying expectations. And what I heard in the first session when we were talking about the maternal Quality Care Alliance, and what you all were suggesting was things like having clear communications and clarifying expectations and those kinds of things. Cubby wrote this book in 2012, as I talked about. I have been doing workshops on building trust a lot since then, and there are lots of other ways that we can build trust that are more context to today. And so some of those are to really understand equity and how equity plays out when we're building collaborative teams. And others are to show vulnerability. These are some suggestions that other people have made during this workshop when I asked them, how do you build trust? What are some other ideas? And so this is a good list, but it's not a complete list. And there's probably other ones that you might be able to add to this list as you're thinking through the ways that you are intentionally building trust on your teams and with your collaborative partners. Cubby then goes on to say, that's about self-trust and the practices we can build in self-trust. He also talks in the book about relational trust, and relational trust he defines as having 4 components to it. One is sincerity. So that is about alignment. So aligning your words with your actions. The second one is about reliability. So making and keeping promises. Competence is one that we don't think of very much. And so when you're asking someone, or someone has volunteered to take on a specific task, whether they're your coworker or whether, you're on a collaborative team with them, do they have the competence to be able to take on the task? So do they have the skills? Do they have the knowledge? Do they have the resources? Do they have the time and capacity? And so competence isn't one that we consider, but when people let us down, it's usually something related to competence. It's usually that they don't necessarily have the time or the capacity. They might not fully have the knowledge that it takes to get that piece of the work done, or they might not necessarily have the resources to be able to fulfill what they signed up for. And then finally, care. And care is really critical to building trust and relationships, because that's about creating connections between people and through people. And so very important kind of consideration in terms of building trust. So I'm looking at my time and I'm thinking maybe we can do this really quickly. Because we have, 20 more minutes. So this is one really fun, engaging tool that you can use to build trust. So hopefully you're sitting at tables where there are lots of people at your table, and there are also Post-it notes at the table. So I'm hoping those are all in place. And so a personal asset inventory asks you as individuals, let's say this table group that you're sitting with is a brand new team, or you're wanting to join the MQCA, the Maternal Quality Care Alliance team. So what are passions and skills that you might be willing to contribute either to your table team or to the MQCA team? So a passion is something that you care deeply about. Could be cooking, it could be photography, it could be your family. So something that you're willing to kind of have fun with. It's something that you do to enrich yourself. A skill is a technical or work skill that you might be able to contribute. It's a couple of examples of skills are things like I can facilitate groups, or I have a good awareness of social media and I'm on many platforms, or I'm good at networking. So if you have, and I'm hoping, Shannon, you'll be able to confirm this for me or not, if you have Post-it notes at your tables, each of you for 2 or 3 minutes, write down on a separate Post-it note each, a passion or a skill that you're willing to contribute to the table group that you're with. And then, so you'll do that for 2 or 3 minutes, and then at your table, begin to Look at what everybody is willing to contribute, passions and skills, and then start to cluster them together and see what emerges, what comes out of your table cluster. So we're going to give you 8 minutes in total to do this little exercise. So I'm going to put on the timer and let you know when the time is up. You've got 1 more minute to fill in your Post-it notes with your passion and skills. And then I'll let you know in a minute to begin your clustering together. And as you're clustering, observe what is happening. Okay, now around your tables, you should begin clustering, have each person share their passions and skills and begin to see what is available to this collaborative group that we formed. So what skills and assets did your group uncover? So hopefully, as you were going through that exercise, you really began to see that people are showing up with the help of this exercise in a different kind of way. They're showing up as people that have passion and skills that they're willing to contribute. And it didn't take us very long. It only took about 8 minutes in total to work our way through this exercise. So it's something you can easily do with your work team or with a collaborative table that you're a member of. It's really a great way of bringing both the hands and also the heart into the work. That skills are really the hand and the head, and passion is really the heart, the commitment that people bring to collaborative groups. And so a very great tool for building connections, seeing where there's alignment across people, and for building trust and relationship, as Kavi talked about earlier. So I'm gonna, in the last 10 minutes, share with you 2 additional tools, because I really believe that, you know, we all talk about trust, but we don't necessarily know how to build trust. And so I really focus this workshop on a little bit of the theory, but really more in the practice of building trust. So the first tool is called the 4 agendas. And this tool comes from our partners at Co-Creative Consulting. They're a consulting firm based in the US, actually just outside of Washington. And they say that when we're building collaborative agendas, we should have 4 parts to the agenda, or 4 distinct elements in the agenda. One part is aligning, right? And aligning is it's really the practice of reminding people why we are there for that collaborative purpose, right? So it's about aligning around an intent or around the shared work, right? So that this is particularly true in collaborative work because people will come to collaborative work from their very busy work lives, and the collaboration might only meet once a month or once every couple of weeks. And so aligning is really critical. The second part is connecting. So really creating those times where we can connect together. And the personal asset inventory exercise is a really great connecting exercise. Another way of connecting is to do what we call at Tamarack check-in and check-out questions. So a check-in question might be, how are we all feeling today? Or what's a success that we've had recently? Or what are we especially proud about? And so the connecting is a really quick opportunity for people to check in at the meeting or to connect with one another. So connecting is really about creating those connections across people. Learning is about learning something new, and everybody comes to a meeting because they want to learn. That might not be an express intent, but they are wanting to learn something. So how do we understand the system better? How do we understand the human experience of the system better? So it's really kind of creating those moments of learning. And then the final part of the agenda should be the decision-making part, right? So what are we doing? What are the tangible solutions that we're going to make? What are the decisions that we're making? And so if you think about, an agenda that has aligning, connecting, learning, and making, you're going to have a very successful meeting, and you're also going to really have make forward progress in building trust amongst participants. The second really important tool that I want to leave with you during the session is this notion of powerful questions, right? And so often we ask people yes, no questions when we should be asking questions that are more powerful, that really engage the knowledge of people in the room, help them think about possibilities, help them kind of raise up their underlying assumptions and their diverse perspectives, and really show curiosity and creativity. And I'm going to show you how to do that in the next couple of slides. Also, they build engagement. So here's the structure of a powerful question, or the art of the powerful question. So less powerful questions typically start with a did you, can you, will you, which of these options are you choosing, right? And so if you think about the did, can, will, many of them are yes, no questions, and then which has you selecting between things, right? So it's which of these. So they are less powerful questions. We use them a lot, but they're less powerful questions. As you start to move up the arc of the powerful question, you start thinking about the when, the where, the who, and then you get to even more powerful questions where it really begin to explore what, the how, and the why. And those are getting deeper and deeper into things like root causes, or how might we do this. At Tamarack, we use the how might we approach for a lot of how we structure questions. And so when you think about collaborative tables, around those collaborative tables, are you asking the less powerful questions or the more powerful questions? And really consider the questions that you're asking the people that are engaged in your collaborative tables. Now, here's a really cool resource that I came across, and it's probably very small on the screen, and I apologize, but you're going to get the PowerPoints. So this is great. This really helps you kind of structure conversations. Now, you can take the whole of this, or you can take parts of it, right? And use that to structure conversations. And so the arc of this is it starts with opening a conversation. So what are you hoping for? What's the goal? What's the issue? what brought you here, understanding what's important is a second kind of box. And it's like, what do you need? What makes this topic we're talking about really relevant and matter? What's at risk here if we don't talk about building trust, for example? The third box is really looking at examining the current situation. So what are the barriers that we have in front of us to building trust? And some of you might say things like time and energy. What stands out for you? What is the reality that we're working in? The next box is around exploring possibilities, and this is more appreciative. Examining the current situation is not as appreciative as exploring possibilities. An appreciative approach is looking for kind of positive based outcomes. So what is possible? What will change? How might you engage with this? So again, you can see the invitation in the exploring possibilities. Then you might want to go deeper and go below the surface. So someone might say, well, I'd like to join your table. Well, then you want to go that one step further. So what would that feel like to you? Or if you felt deeply engaged, what was that experience for you? So you can see that going below the surface is taking the exploring possibilities conversations and going one step further, probing for clarity, and then closing the conversation. So a really great tool for kind of thinking about the types of questions that you might ask in a collaborative context that really build trust and connection. And so I'm going to just wrap up really quickly because I know we only have a minute left. The threads are connecting. So those of you who participated in part one learned a little bit more about MQCA and collaboration. In this one, we're talking more about trust and relationships, but we know to move the MQCA forward, what we heard from you is that we have to build trust and we have to build relationship. And we know that trust doesn't just happen, it's an intentional practice. When we meet again on January 17th, we're going to talk about, how do you navigate turf? And what do you do when trust breaks down? So we hope you'll join us then. I know that we have only a minute left, so I'm going to turn it over to you, Sultana, just to do a little bit of a wrap up if you're in the room.
All right, thank you, Liz. So I was just going to summarize everything. So we set the stage in the first session, just talking about community impact and what areas do the MQCA need to incorporate in our plan. We also talk about how to build trust in ways where we're trusting ourselves, relationships, organizations, market, and the society overall. And like Liz already mentioned, we have a part 3 coming up on January 17th. Oh my gosh, no, I'm nervous. From 12 to 1. I appreciate if you guys come and join us and we talk more about building trust and other aspects of TERF.
Great. So I think now we hand it over to Shannon for instructions about next steps.
Thank you so much, Liz. Thank you, Satana. Thank you, Nitika. And thank you, Jamia, who already left. And who am I missing? Am I missing anybody? Stephanie. I bet you guys, I texted her throughout this whole thing and I kept sending pictures. So she was with us in spirit. Okay, so really quick, I know you guys all want what's in my hands. And I'm going to turn it over to Arthur here in a few seconds after I draw names. But if you get a prize, please stay and listen to Arthur. Don't leave. So, because this was the carrot to keep you all here to hear Arthur. Okay, so Sabrina, where are you? She was going to be my runner. She might be loading the car. Okay, you guys know the drill. I'll call the names. Oh, Natika's gonna, and you guys just shout out what you want. We have blankets, cups, charcuterie boards, and the belt bags. Okay, We have Dane De Silva. What do you want? The board? Okay, the board. Rebecca Crease.